Thank you, Dr. Ashok Seth,
Thank
for
you.
this. Thank you very
Thank
much.
you. I must say, it's always a pleasure to be with you all. I wish I could spend more time. But, when I saw that screen, I said, I have so many people who trained with me uh, uh, who are in Bangladesh. And I saw that all of them have become such great cardiologists. And it is a pleasure to hear Kaiser Nasrullah presenting that retrograde case. I still remember the time when he trained with me, and what a remarkable skills and expertise and talk that he's given. I know many of you who've given such talks and who've trained with me all are doing so well. But I was actually just heard him, so I was just feeling very proud. Now I'm going to be brief, and I have my friend Arun Kalyanasundram also on the chair. Can I just request you to time me, because I would not want to go over time. I know you all running late. This time I'm just going to be functioning for the sake of teaching, and I'm talking about not high risk cases, but I'm talking about complex PCIs, and I'm going to give you some tips and tricks which are going to be useful. Many of you may know it. Maybe it's more for the audience who's listening to you. There are numerous young gen interventional cardiologists in Bangladesh. It's always a pleasure when they present cases. I mean, you've got a real enthusiastic students, fellows, young interventional cardiologists who are always eager to learn. So it is our job not to just skip through slides and talk high, but also to talk at a level which helps them in their cath lab. So this is what I'm going to do today. And I'm going to go straight off by reminding you that when we talk about high-risk complex PCI, we have a spectrum of increasing high-risk cases. These days, as the age grows older and we become more proficient and we are able to take on more cases, there are numerous surgical turndowns. There are numerous people who've had previous bypass surgeries. There are patients with highly calcified lesions, long lesions, left main diffuse disease, bifurcations, left main bifurcations. And then, of course, there's this whole group of people who've got bad hearts, impaired left ventricular ejection fractions, impaired hemodynamics, along with the fact that they're elderly, they're high bleeding risk patients. So we have a conundrum of trying to learn numerous techniques and technologies and mastering them for the best outcomes for our very high risk patients. Now that's another aspect that we'll talk about at a later. But today I'm going to go over some very simple basic stuff. See, I'm going to talk about intervention in anomalous coronary arteries, firstly, and give you some tips and tricks around that. So this has been with us all the time. Nearly we have at least 2 to 3% of our interventions in anomalous coronary arteries. But the anomalous right coronary artery is always a difficult game. And actually, mastering that separates the men from the boys. But let me just take you back into our lifetime. It's always great to see, how we pushed balloon angioplasty forwards. And this is a case from 1991. So those are balloon angioplasty days. We're talking about 30 years ago. When I took this case up, you can see it was balloon angioplasty, preliminary hardware, poor technologies, poor antiplatelet therapy, no stents, just balloon angioplasty. And we have this long right coronary artery lesion. You can see that. We have an anomalous left main arising from the right coronary sinus. The anomalous left main has an ostial LAD, then a long multiple diffuse disease circumflex. Now, even in the present era of stents, we would be really wary to take up the ostial LAD. It's a left main bifurcation, and then take up long diffuse segments of circumflex as well as long RCA. We would consider surgery. This is a high-risk case. But we were pushing the boundaries of interventional cardiology forwards. Here is the ostial LAD, here's the circumflex, here's the anomalous left main. And I did balloon angioplasty to this all in one sitting. 91, it was all opened up this with balloon, went to the ostial LAD, blew a balloon into the left main across the ostial LAD, just balloon angioplasty, and you can see nicely opened up the whole circumflex with balloon angioplasty. Well, I then sent this for publication, and 3 journals refused it completely, saying that you are mad to do such angioplasties. We don't want to give an impression that interventional cardiologists should do such balloon angioplasties at all, and it will be wrong, and therefore we will not publish this case. Well, 2 years later, this guy comes back with chest pain, and lo and behold, he's got a new lesion in the distal RCA, but all these lesions with balloon angioplasty are actually doing fine, and so is the ostial left main. And now I send this paper for publication. Well, the journal accepted it, saying, we didn't know balloon angioplasty was as good as this. This is remarkable. This actually shows that balloon angioplasty can work in complex multivessel disease, and that's the Journal of Interventional Cardiology. In 95, after 4 years, when I did it in 91, that finally this got published. Moving to this case, which is an anomalous RCA. This is a patient. Let's not go through the history. That's not so important. I think this is important that this is an anomalous, but it's not just anomalous. This artery arises high up on the anterior wall from the left coronary sinus. That's why you can't see the left main opposite it. Otherwise, normally the right coronary artery arises just opposite, even if it arises from the left coronary sinus, arises anterior and at the same level as the left main. But this is totally different. So RC is being engaged, the diagnostic JL5, AL1, and you can see I just can't get it close enough because it's high. It's higher than the left main, arising anteriorly from the left coronary sinus. What do you do? This is a diagnostic AR2 was modified, a diagnostic was modified, and the way we modify catheters, and you need to learn this because twice a year I have to end up modifying guiding catheters. RCA was engaged, and the way to do it is, and I'll just tell you how to modify it. So the lesion was crossed with a BMW wire. Now this is through a diagnostic that it gets crossed, and you can see it's high up. And an all-star wire is passed for support. Now, once you've got these, then you're okay. The diagnostic, you pass the wires down, you've got an all-star, which is a support wire, and then you're able to actually modify a guide. And the way you modify it is, it's hot water and cold water. You use the mandrel of your wire introducer, shape it in a manner that the primary curve has to point anteriorly. So the primary curve points anteriorly. That's what I'm doing in this. You can see that the primary curve is made to point anteriorly. And here, what I've done is made the curve bigger. So the first I shape the wire introducer in the same manner, make a bend on the wire introducer, then dip it in hot water, put the wire introducer at the tip of the catheter. Now I dip it in hot water, leave it in boiling hot water, leave it there for a minute, immediately ice cold water, leave it there for a short while, and then take the mandrel out, and I'm ready to go in. Use it with 7 French guiding catheters because they may tend to retain. And here it is over the wire. And how do you take it over the wire? You firstly keep the loop. You can see there's a loop out there of wire that I leave. It's a total loop. Then you get a guiding catheter. To get the guiding catheter with an 035 wire and the 014 wire together, and bring the 035 wire till the aortic root. And from there on, you just take the 035 wire out. And this loop is a very important loop so that this guiding can actually go over the loop. And now it sits extremely well and coaxial into this anomalous left main. And now it's coaxial. Once it's as coaxial as this, then you're, of course, able to do anything that you want and complete the procedure. So I've always said that it separates the men from the boys. When you do this, here's another case where the common way to engage an anomalous is inverted Judkins, as you see here. But again, in this case, while this is, this is higher and going between the pulmonary artery and the aorta, but this is higher than the normal anomalous right coronary artery. Engaged with a Judkins guide, you give a clockwise twist. You invert it in the left coronary sinus, give a clockwise twist, and then slowly take the 035 wire out for the Judkins to prolapse into what would be an anomalous right coronary artery, which is high, and going more from anterior backwards to posterior. Again, all-star wire passed down. I think what we have here is, again, the diagnostic catheters changed over the guide wire, and you will see that I'm leaving a loop. This is the guiding coming in, or is it... And yes, I'm showing you that it's between the PA and the aorta. Distal lesion was centered. Well, maybe this is not, but this one is important. This I couldn't get. You see a total occlusion of the right coronary artery, a CTO, and I cannot by any means Even with the inverted catheter, you can see I can't get it. Even with the amplets, I can't get it. I have absolutely really frustrating situation out here. I modify the catheter again. You can see I've created a anterior grade bend onto the guiding catheter, a 7 French guiding catheter, and that makes me actually arrive to a more coaxial position on this anomalous left vein. And then I'm able to, through balloon support, I'm able to pass a guide liner into this into this anomalous right coronary artery. You can see that happening on the right side. And once I've got a guide liner inside this, I'm able to open up that total occlusion, then stent it through that total occlusion, and then finally have a good result on that right coronary artery. So I'd like you to refer to my editorial in CCI. It says, understand and use your rights. It tells you exactly how to do these things, how to modify guiding catheters and what catheters, and how to understand it three-dimensionally the anomalous right coronary arteries. Now I just want to take you through some other tricks. Arun, what am I for time at the moment?
Go ahead. No, this is such a great talk. We're not stopping. Go ahead.
So this is
you have 10 minutes. That's it.
Okay.
You're good.
46 years old lady. This happens to all of us. A right coronary artery lesion, straightforward. Many of you say straightforward. It's fine. And yes, it is straightforward. Here it is. RCA was mid 90% anomalous circumflex arising from the right coronary sinus. You can see that. Yes, you can see the anomalous circ coming out from proximal part of the right coronary sinus, and the LAD was normal. So no big deal. Our circumflex also has a stenosis, as you can see proximally on the right panel. And so I didn't think much of it. I just went ahead, dilated, put a stent, because I said I'll come back for the circumflex. I'll do that. Here's a stent going in nicely, all fine. And then I dilate it, post-dilatation done with 18 atmospheres. Everything looks good. And I take a final injection and everything looks good. And I take the wire out and the vessel closed. The patient suddenly starts having chest pain. This is exactly what happens. Now that picture is not here, but you can understand that now, because the moment I took a puff, the vessel was gone immediately. What had happened was I dissected the ostium. The moment this wire came out, the vessel closed up straight away, hypertension, ST elevation, severe chest pain, and that shot didn't get taken because it wasn't fluoro saved. And now I've had a problem. I can't get wires from my guiding catheter into the vessel because it keeps going into the dissected path. So what do you see me doing? How do you actually get into an ostial dissection when the wire is out? And by the way, this happens, your fellow may be doing an angiogram, he dissects a right coronary artery. It's happened once in everyone's life. A normal right or a diseased right gets dissected and occluded. And it's almost impossible to get into it because you put in a guiding catheter into a dissected ostium, it'll go into the false lumen. And because it keeps tracking the same false lumen, and your wires will keep going right from the ostium into the false lumen. It's very difficult to find the true lumen, and this is how you do it. Use a diagnostic catheter. Here is the diagnostic catheter on the right side. You will see that you've got to sit, actually not at the ostia. You're not into the ostia. You've got to sit into the sinus. And then with a very soft wire, try and find a different path into the ostia. You see my left image? I'm trying to pass a path, and you can see the staining of the ostia. I've dissected that ostia quite badly. Finally, your soft wire indirectly will find a path. You may use a diagnostic because that's easy to keep in the sinus, but you can also use a guiding, a 6 French guiding. Park it into the sinuses and surf the ostia, as we call it. Find the true path. And this is so important. This is the only saving grace that you can actually have, not by going into the ostia with a guiding catheter. Once you've done that and gone down, then of course, I then replaced it with the same technique I'm telling you. Leave a curve behind in the aorta. The diagnostic goes out. The guiding is now coming in over the wire. You can see 035 and 014 wire together. Once the guiding comes to the aorta, the 035 comes out. And then you watch this. The next one is important. On the left, I am now got a loop here over which I'm turning the guide to enter the aorta. It has to be with a loop, otherwise your wire comes out. So there's a loop. I'm actually pulling the loop back as I give a clockwise twist to the guiding catheter and I'm in. Of course, no further injections. Just stent the ostia is what you got to do. I stented the ostia. And by the way, because there were no further injections and had ostial dissection, I had to come all the way out to the ostia, which meant that I had closed off the circumflex, enamelar circumflex, which meant I had to cross the circumflex and through the struts of that stent. And once I crossed the enamelar circumflex to the struts of the first stent, I then did a tap to the RCA stent for the enamelar circumflex. So that's a tap. And finally, I had a great tap result with the treatment of both of those. So I think I was able to get a very good result, as you can see here in this. Now, I have actually, and then because of the staining, I went ahead and made sure my left system was also functioning fine. This is all just optimizing it and making sure my left system was fine, because I've had a situation where you can keep on injecting, the hematoma keeps expanding, and I didn't do that. Somebody else did it. The hematoma kept expanding in the aorta. It expanded to an extent that it was closing off the left main, and the ostia of the left main had to be stented to prevent a collapse of that patient, because continued injections led to further extension of dissection into the aorta. Now, I'm going to actually, so that's, okay, maybe this is where I'll end. So this is an aneurysm, and all of us will come across aneurysms. And huge aneurysms as bad as this. This is a giant aneurysm, defined as more than 4 times the normal vessel diameter. And you can see it's huge. Length, width, and we don't have any form of covered stents to close it. Normally, it's been thought that giant aneurysms should be treated by surgery, but if you can close it percutaneously, far better and far easier. After all, this guy shouldn't have a surgery for a right coronary artery aneurysm. He actually presented with a non-Q infarction. His enzymes had risen up. This is what was a finding at another center when an angiogram was done. He was advised surgery. But we were able to close these. And the reason to understand it briefly is, the way to close it up is, of course, that you can actually create, and that's not been reported, by the way, and that's why I've already put it into a report and it's awaiting review because it's got a 2-year follow-up. So here's a hockey stick guiding catheter for good support. You saw it was a hockey, it was a Shepherd's crook RCA with a large aneurysm. And we decided what to do is to create an outer scaffold of multiple drug-eluting stents. And in that outer scaffold, put in the covered stents. You know the covered stents come only in 16, 19, and 26 millimeters length, the Graft Master. And similarly, if you're using PK Papyrus, from Biotronic, which is not available in most of our countries, and it's certainly not available in India because it was withdrawn by the company itself. Then we have, again, similar lengths, maximum of 26 millimeters. So this perhaps needs nearly 50 or 60 centimeters of length to cover the aneurysm. So therefore, create an outer scaffolding of a drug-eluting stent, and that's what we did. So we have then a 38 drug-eluting stent. Yeah, it was 38 Zynes, followed by another 15, followed by another 12, till we created a scaffold from the distal normal segment to the proper normal segment. And that's what we've done. Having created a scaffold of outer drug-eluting stents, and that is what this shows, we're now passing on the right side, you see, that image is that we're passing a 26 millimeter Graft Master, implanting it at high pressures, and another Graft Master, which is, I think, a 19 millimeter Graft Master, within the outer scaffold of Zynes. At least a 6 millimeter overlap, and I'll explain to you why. This is a 4 millimeter Graft Master, the 4.5, dilated to a high pressure with 4.5 balloons all the way, till we actually have a closure of that aneurysm. And by the way, we now have a 2-year follow-up just a month ago. I should have put that here. Absolutely closed, artery looking patent, no restenosis, flowing vessel. But the thing you want to understand about Graft Master, and I think that will be my last part of the talk, is I want to give you some tricks of the Graft Master, not for the aneurysms, but for the sake of perforations. By the way, You just saw Dr. Daggubati's talk. He was saved multiple times by the Graph Master, and you have, I hope you all have it in your labs. It's your biggest saving tool for perforations. But you have to start understanding the device itself. And I think there's a lot of still lack of understanding. I want you to understand that Graph Master, it's the same stent, whether it's 2, 3.2.8, 3.5, 4, 4.5 or 4.8. It is the same stent. Please understand. So if you even have a 2.8, you can expand it to 4.5. It will close off your perforation in a 4 millimeter vessel. So that's the first thing. It's not different stents. So don't say, oh, but I didn't have this Graph Master, so I didn't know what to do. Even your 2.8 will cover that. That's the first point I want you to understand. It goes, the 4.5 and 4.8 will grow larger. The second part we want you to understand is that it's two stents with an inner lining. The two stents means that it requires higher pressures to expand completely. That's the second point. So it only gains its nominal at 15 to 16 atmospheres, but is mounted on a very expansile balloon. So if you take it to 20 atmospheres, it'll increase by 0.5 millimeters and you'll have edge ruptures of your vessel. The 2.8, supposing you have a vessel of 3.5, what does a 3.5 graft master mean? That means that the outer diameter of the graft master will become 3.5. But remember, the graft master is 0.5 millimeter. It decreases your whole lumen by 0.5 millimeters because it is 250 microns thick, which means that your vessel becomes 3 millimeters. What does it mean? It means that when you implant a graft master, you only implant it at 16 atmospheres, then go in with a high pressure balloon and actually inflate it well within the edges to take it high. If you implant it at 20 atmospheres, your edges in a 3.5 become 3.8 and 4, and you will have edge perforations. Finally, the third thing you need to understand is that Graft Master doesn't cover edge to edge. Its lining is at least 1.5 millimeters inside the edges. When it expands further and further, the whole Graft Master shortens in length. Your 26 millimeter Graft Master or a 19 millimeter Graft Master will become 17 millimeters on expansion if you expand it to 3.5 and 4. And by the way, the covering will become even shorter, will be 5 millimeters less. So that is the reason why sometimes the Graft Master doesn't close off your perforation. So use a long Graft Master. Make sure that if you have to overlap it, that it's a 6 millimeter overlap, and make sure that you actually go inside with high pressure to close off your perforations, but do not blow it up to 20 atmospheres because otherwise you'll have perforation from the balloon at the edges. And if you want to read any further about it, go into these two editorials of mine, which will give you a whole detail about coristent grafts and how to use them and how to make them savior. I think I'm not going to take you any further. I was just giving you certain tips and tricks, especially for the young interventional cardiologists to actually make their angioplasties safer and more effective and come out of difficult situations. Thank you very much for your attention.
Thank you, Dr. Ashok Sheth, for your brilliant speech. When we were the training of under you in 2001, you told that I have no credit now. I have credit when a stent did not come. Then I have do many things without a stent, as because there is no stent.
Yes,
and
right.
you told this.
Professor Jalaluddin is another of my favorite students who's shone so well internationally. So
after the training, when we came back to Bangladesh, the night before the come back to Bangladesh, we met you, Khandakar Kamrul Islam, and
Yes.
you told that your first case in Bangladesh will be your case. And you have also named another consultant who is in the very top position in Bangladesh, that he worked with 2 months with me. You have worked 6 months. Why you will not do? You will do many things, and
Yes.
you remember it.
No, it's
And your work is, we have seen at that time, you are really master of masters, and we always follow you in different works. And you told this, whenever you get a complication, then you will think that my face is in front of you, and then you will be able to overcome.
Thank you so much, all of you. I really have a lot of longing and a lot of loving for you all.
Yes, sir. For your speech, I have nothing to do. I have seen it. And our chairpersons here, Professor A.K.M. Fazlur Rahman is there, and your Dr. Shukshet Imad Shiban is not here at the moment. He is coming later on.
And Yamana Zaman, I see him.
Yes.
Hi.
Dr. Arun.
Thank you, sir.
Dr.
Thank you.
Arun,
Thank you, sir.
would you like to comment on his speech?
No, it's truly an honor. I mean, I was lucky enough to work with him for well more than a year, so we had really good times. I mean, this was a master talk, and I know he said time it. There were like just so many pearls, and like it was just an amazing talk. Really enjoyed it. I mean, he's a master storyteller. Learned so much. I'm sure not just the younger interventionalists, but I think everyone can learn from Dr. Seth. I mean, just watching him do stuff was just pure magic. Great talk. Really enjoyed it.
But I must say, Arun and I have worked together. I was instrumental in getting him back from Seattle. Seattle is where my daughter lives. I was giving talks on bioresorbable scaffolds when I met him. And I said, you have to come back. And I got him back to Escorts. We worked together. What a time. I mean, this is a master of total occlusions. I have a lot of affection for him because I think he's very skilled. So if you people want to learn total occlusions, learn it from him. We worked together. We did so many complex cases. We were in tandem with each other. And I think he's opened up a hospital in Chennai. So he moved down more permanently than coming to Escorts regularly. But it's still always, I keep thinking of him multiple times.
Our panelist, Professor Khandakar Kamrul Islam, Professor A.Q.M. Reza, Professor Mohammad Shahabuddin, my friend, I think he is here. Shahabuddin,
Yes,
Dr.
sir.
Jihad Khan, and Dr. Ashok Dotto from National Heart Foundation Hospital and Research Institute, Dr. Diman Bonik. If nobody is there.
No, Dr. A.Q.M. Reza is here already. Doctor.
Okay, sir.
Please go ahead.
A.Q.M. Reza.
Go to the next talk.
Dr. A.Q.M. Reza.
Hi there. So I'm Dr. Nitra. Shall I share my slides?
Yeah, I'll switch off my slides.
Okay.
Sorry. I hope my slides are off.
Yes, sir. Your slides are off.
Okay. Thank you very much, Ashok Shet sir, for your wonderful teaching. You are the master of masters. Actually, you are not working for success. You are working for satisfaction. That's why we learn a lot from you, because a legend always works for satisfaction. Now I am requesting Professor Dr. Shuk Ginger S. Nair. He is the president of Royal Society of Medicine, Cardiology. He is the consultant cardiologist of Imperial College National Health Service Trust. I am requesting for his talk, using co-registered physiology, interventional imaging and angiography for complex coronary artery disease. Can you share your slide? Then I think our next speaker, M.S. Hiramat sir, should be ready for your talk. Thank you very much, sir. You can continue your talks.
Okay, so you should be able to see my slides now.
You can share your slide first.
Yes, I have. So I'll share them again. So I can see them shared on my side. Hopefully you can see them shared on yours. Can you see them okay?
Yeah,
Yes.
we can.
You can, fantastic. Well, thank you so much to the Society for your very kind invitation. I'm very grateful and I appreciate it's late in the evening for you in Bangladesh. It's still working hours for us here in the United Kingdom. It's a great privilege to be speaking to you today. It's a little different, my talk, compared to many others in the session. Learned some great tips there from Professor Seth there. Just some amazing work and important points with the covered stent. I'm going to be talking about integrating the use of physiology and imaging for complex coronary work. And as the other speakers have said, we're doing a lot more complicated work these days because of surgical turndowns, and particularly in the COVID era where we've been asked to intervene percutaneously rather than perform surgery. You can simplify your intervention if you use physiology. These are my disclosures. I've had previous honoraria from Philips. And of course, we are in the interventional era, but not all of our interventions are appropriate. Many of you will have seen case reports like this. patients that got full metal jackets of their coronary arteries, and you have to wonder how many of these 67 stents were considered appropriate in the United States, where they have appropriate use criteria. And the European Society guidelines have suggested you must document ischemia, and this is our practice in the United Kingdom. So if patients have not had ischemia testing before they come to the cath lab, then we will undertake a pressure wire assessment, and we'll either use IFR or fractional flow reserve before performing coronary intervention. And we do this routinely at one of the hospitals I work at, the Hammersmith Hospital. We are some of the highest volume pressure wire users in the whole of Europe, I am told. And this is partly because we are biased. We were the academic group that led the development of the IFR technology. And so I'm going to move away from just talking about yes, no in a moment and talk about identifying lesion level ischemia. But before I do that, I'm going to mention to you about vessel level ischemia, because that is how most people define coronary physiology. So we do this using pressure wires, and you can either measure something called IFR, which is at rest, or you can measure fractional flow reserve by giving adenosine, and you can give that IC or intravenously for 1 to 2 minutes. IFR is a resting index. It is measured at rest. It is quite quick. It only requires 5 heartbeats to get a steady state, and then it will give you a computation as shown on the left graphic. And there's a huge amount of data to support both IFR and FFR, and I'm not going to labour the point. There is a huge amount of data that comes from the DEFER study, which is relatively old and involved a lot of patients having bare metal stents and POBA alone. FAME study, a more recent study in the first generation drug-eluting stents, again showed intervention guided by a fractional flow reserve was superior to stenting all lesions over 50%. And then in the FAME2 study, which was considered a positive study, although remember it was stopped early, also demonstrated that intervention in ischemic patients does better than medical therapy alone. This is a grouped meta-analysis of a number of different studies that also shows there may well be a prognostic advantage for intervention guided by fractional flow reserve, although they have included a number of different types of patients here. FAME2 was predominantly stable, DINAMI3 was predominantly acute coronary syndromes, and so was COMPARE acute. So slightly disparate populations that have been combined there, but guiding your intervention using physiology has been shown to be superior to using angiography time and time again. Then we came along from Imperial and produced this as a new kid on the block, which is IFR. This is measured at rest during what we call the wave-free period, which was defined using something called wave intensity analysis. That is far too complicated and not really necessary as part of the analysis. It can all be performed at rest. We're using a pressure-only signal. We don't even need ECG anymore. We know it works compared to other ischemia parameters, and it doesn't matter which ischemia test you compare it to, whether you use HSR, SPECT, PET, or stress echo, or perfusion PET and perfusion MRI we've got data on now. IFR and FFR are equivalent in their capacity to define ischemia. When you compare it to CFR, IFR seems to be superior, and it's remarkable that a resting index like IFR is better than fractional flow reserve in defining flow limitation. And there are some idiosyncrasies to explain that, but I can answer it if any of you are really interested. We did 2 very large randomized control studies, IFR, Sweetheart, and FLAIR. FLAIR was the double-blinded study performed in 50 centres across the world with 2,500 patients. Sweetheart was the single-blinded study that was performed in the Swedish countries in a randomized registry. The data studies were co-aligned and co-designed so the data could be put together. And when you put the data together, 4,500 patients is the largest set of physiology studies done to date, and it dwarfs all the FFR data. We were able to show that IFR and FFR are equivalent when you look out to 1 year. And if you look at the 2-year data, you can also see that there is no real significant difference, although the numbers change ever so slightly. So we've been able to show over a number of years that IFR is a technology that can help guide intervention. But the problem that keeps coming back to interventionists like myself and Emmanuel, who will be speaking after me, is that unfortunately it doesn't matter what you do, but patients have recurrent angina after you performed intervention. And this has been shown time and time again If you look back in the original bare metal studies, if we look at even in the more recent drug-eluting studies, around 20 to 30% of patients have ongoing angina. And it may well be because we are targeting the wrong lesions. And this is seen predominantly if you measure your fractional flow reserve after you performed intervention. Many patients are still ischemic. They still have FFR values below the threshold of 0.8. And this tells us that perhaps we have not done good enough intervention. Although this is commonly attributed to diffuse disease, there's actually data to suggest it's not. And I'll come on to that in just a moment. Now, does it really matter? Does it really affect the patients? Well, data continuously shows, both old data from Mika Pills in an early generation stents and even more recent data from the Korean group, they have shown that if your fractional flow reserve after intervention is low, you will have bad outcomes for your patients. So it makes sense that we try to define the lesions that are causing ischemia, not just the vessels. So this is turning physiology from just saying it's the circumflex, it's the LAD, and then you guide your intervention purely by the angiogram into something a little bit more novel. And this is some of the work that I did as part of my PhD, which was to take a pressure wire, to pull it back within the vessel and to map out the pressure loss within the vessel, and then co-register that information with the angiogram. And you can then start working out where all the pressure loss is in the vessel. You can identify focal steps and diffuse disease as well. And then once you do that, you can start to estimate what your IFR is going to be after intervention is performed. And I chose, when I was doing my PhD, to present it in this kind of format. But in the end, what we ended up doing was using this DOTS format to integrate that with angiographic data and to make it much easier to use. And that's because as interventionists, we're very visually minded. And if you can co-register your pressure wire data onto the screen, you can see where the pressure loss is. We can then target that more easily. And so this has then been commercialized now and is now available in cath labs around the world. And it now looks a little bit like this. This is what the raw pressure trace looks like. You produce a pullback within the vessel, and you see steady states where there is no significant lesion. You see diffuse disease where there is diffuse plaque, and then you see very focal steps, as you can see here, whenever there is a focal stenosis that warrants intervention. That can then be integrated onto the angiogram in a live manner in real time so that we know exactly where the lesions are. And in this RCA, where there is a significant focal stenosis here and here, we can see all the pressure loss in this vessel is predominantly driven by this particular lesion, and then you can interact with that lesion on the screen and make your intervention far more targeted. So in this vessel, this is the kind of patient that we're typically dealing with these days. He has quite significant disease in his LAD, and our eye is naturally immediately drawn to this very focal lesion here, and we may choose to intervene with a single stent, maybe put a 2.5 stent in this segment here. I think we've got a good result. But actually, if you look on the pressure wire trace, then you will see that there is significant ischemia in this vessel. And if you've just placed a focal stent in this vessel, you will not render this patient non-ischemic. So the gain in this little segment is only 0.08 IFR units. And when you add that to 0.64, which is the total IFR in this vessel, you will still be ischemic. And that's because there's a lot of pressure loss here. And so you may be better off either doing complete stenting or probably in this case refer for a lemur to the LAD. Now, we've assessed this a lot more detail in the defined PCI study. This is a study that was predominantly performed in North America with interventional centers that had high volumes, highly experienced in performing physiology and intervention. And what they did was they performed intervention in ischemic vessels, so they had to have confirmed ischemia. They then did an IFR pullback, but they were blinded to it. They weren't allowed to see where it was. And they had to then say that they'd completed their intervention, and we measured the pullback after they'd performed it to see how good their intervention was. Okay, so really this is a study to look at your post-PCI IFR value. And these are kind of values that cases that they saw. So very, very significant disease in this LAD, very, very tight distal LAD stenosis. IFR was measured 0.39, so very significant. Some of you may be surprised by this, but obviously the IFR was mandated as part of the protocol. So very, very significant. No doubt there is ischemia here. The lowest IFR value I've ever seen is 0.12, so pretty low. And then they've intervened and performed stenting here. But what they've done after they've done their stent is remeasure the IFR. And this after the interventionists thought that they were complete. They'd removed the lesion. But actually, unfortunately, the IFR after their intervention was still highly significant, 0.74, so still ischemic. So it's unsurprising that this patient is going to continue to have chest pain and symptoms after their intervention. And the operator didn't know at the time, but actually there was a huge amount of pressure loss in this more proximal segment of the lesion. And if only they had the IFR pullback data before they performed the intervention, they would have known that this apparently more moderate stenosis also needed intervention. So it's moderate by angiographic appearance. I bet if you stuck an IVUS catheter or OCT in there, you would see that there's very significant ring calcification. So the overall DEFINE PCI study showed that in patients like this, where operators think they've got a good angiographic result, they're very pleased, they don't plan to do any more intervention, 25% of them still had ischemia, 25%. And that's remarkable because remember I told you that post-intervention, between 15 and 25% of patients have ongoing angina. Okay, so it's possible that these are the same kind of patients that we have not intervened on the right lesion. And then when you look at the pullback traces and you look at the data, 80% of these patients still had focal disease on their pullback trace. Focal disease, and that's important because we can treat focal disease with a further stent. So you could imagine that if we had targeted intervention using IFR pullback traces, co-registered, we could get much better results for our patients, certainly for symptoms. And when you look at the data, around 40% of these patients still had a pressure loss within the stent. That means the stent result is not optimal. They may not have got adequate expansion. Around 30% of it had a further stenosis proximal to their stent. So it means they probably targeted the wrong part of the vessel. And in another 30%, there was significant pressure loss distal to the stent. And distal disease is not always easy to treat, but perhaps could have been targeted because these were all lesions that the core lab felt they could have intervened on. So what we take away from this is if we were able to target our intervention better using a co-registered pullback, we would then get much better results for our patients, and we could remove residual ischemia from around 25% down to about 5%. Now, I'm going to show you this case because I think this is an instructive case of the kind of patients that we deal with day in and day out now. Patients have multivessel disease and often are surgical turndowns for many, many reasons. And in this particular case, you can see that this patient has 3-vessel disease with severe disease in the right coronary territory, in the proximal LAD, and also in the circumflex. And we performed an IFR pullback, and we can see in this blue line here, which is shown in the PDA, the IFR was strongly significant, 0.78. But when we performed it in the PLA or in the PLV vessel here, we can see the IFR is even lower, it's 0.65. So if we did what we would typically do, which is intervene in the PDA across here, we would actually not be helping the most ischemic part of the vessel. We then put an IVUS catheter down, and this video shows a co-registered IVUS. This is all done manually. It doesn't require a motorized device. The angiographic equipment is constantly tracking the movement of the IVUS catheter. It's got 3 markers on this particular IVUS catheter, so the machine knows exactly where it is. And we can see there is extensive disease at the bifurcation. And what this system will do is, if I can skip on ahead, will co-register the IVUS image to the angiogram. So what you can do is actually click anywhere on the angiogram and see the IVUS result co-registered, okay? For me, I find this incredibly helpful because IVUS is great when you're looking at it live, but afterwards, after the IVUS is done, when you look back at pre-stored IVUS images, it's not always possible to know where you are in the vessel. Here you can see the operator can drag on the angiogram and make measurements in the vessel. So he knows that if he's going to intervene on this vessel, up to there, he's going to need a 30mm stent. I can actually measure the landing zone here and see that the vessel is around 2.5 in diameter. Okay, remember on IVUS measurements, you need to go a quarter size down. And because this part of the vessel is very large, it's not optimal to put one long stent into the PDA all the way back. So what they ended up doing was measuring into the PLA, and because that was the most ischemic vessel, that is where they performed their intervention. So they chose, as you can see here, this is a measurement of IVUS in the PLA, and this marker here is where this IVUS is, and you can see this PLA is massive. He's getting a reading of around 4 millimeters, and therefore we can safely take a 4 millimeter or 3.5 millimeter stent into this distal RCA into the PLA, which is exactly what they chose to do. And you can see here is the post-angioplasty result, and they've got a angiographically very nice result. And also, I'm sorry, I don't have that slide, when they reassess their IFR in this vessel, it is no longer ischemic. Okay, so we have targeted our intervention into this segment, which was the most ischemic segment. We've deferred the intervention in the PDA, which was less ischemic and is a much smaller vessel. The circumflex turns out to be non-ischemic and confirmed on a resting measurement and on a pullback trace, and I'll skip past for the interest of time. But here is very interesting with the LAD. We see there is significant disease in here in the proximal segment and then a further moderate lesion. And you can see the IFR is 0.81, very significant at rest. Remember, the threshold of treatment for IFR is 0.89. So this would be equivalent to an FFR of around 0.70 or around 0.65, so prognostic values. And what they do is they then do a co-registered IVUS in order to establish landing zones. And this makes our intervention a lot easier, and we can guide our intervention in a much more targeted way. You can see that there is extensive plaque in the proximal LAD. Where you think there is a landing zone, in fact, there is not. You can see using IVUS that this area where we were hoping to land our stent actually has a very significant volume of plaque, and therefore we are likely to have to try and so-called nail the ostia or stent back into the left main. Now, in this particular case, the operator tried to nail the ostia. He got a few struts back across the circumflex, but the overall result was very good. And there they're making some real-time measurements in the distal LAD to make measurements of where the landing zone is. They can see that this is accommodator 3. Proximally, the landing zone will be around a 4. And so they can measure the length of the stent as required. It's 32 millimeters. And so they use a 33 drug-eluting stent, 3.0 according to the distal landing zone, proximally optimized with a 4.0 NC to high pressure. And then they perform an IVUS assessment, and they can see that they have got good expansion and full apposition with no malapposition at all. And on the live IVUS, which hopefully you'll see here, there is a few struts that just extend beyond the ostia of the LAD, but there is nothing covered in the circumflex. So what this case shows is that you can do targeted intervention much more focal than covering the patient entirely with metal. And that's the final result. Now, many people ask about the diagonal. You can use pressure wires to assess the flow in the branch vessels. If there is data to show that if the flow is good, then you do not need to intervene. So I'm going to conclude there to say that you can use physiology to assess for vessel level ischemia. This is well established and known for many years. You can now measure ischemia at the lesion level, and you can now target intervention by combining angiographic co-registration and IVUS trial registrations to know exactly what you're dealing with for precision BSCI. So with that, I will end my talk. Thank you very much.
Thank you, Dr. Nigeri from UK. He is the president of Royal Society of Medicine, and now he is working in UK. And he has taken very nice lecture. That is what you know nowadays, physiological aspects of intervention. And he has nicely shown IFR and FFR, and it is told that after coming to the FFR, number of angioplasty has been reduced to 24 to 25%, as because we are getting the exact picture whether it is necessary to do an intervention or not. I think Professor Nigeri is with us. We want to comment from him. Sir. Dr. Ekimam Reja. Professor Ekimam Reja. Raja bhai. Professor Ekimam Reja.
No, Kandakar Kamrul Islam.
Kandakar Kamrul Islam. Professor Kandakar Kamrul Islam.
Good evening. Thank you, Dr. Nizar, for your wonderful, excellent presentation. With the help of physiology study by using FFR and IFR, we can we have a good result and reduce the mortality and less
Thank you very much.
physiological measures. With the help of these physiological measures, we can give a better result, and by reducing less mortality and less adverse effect if you compare without physiology study. Thank you very much.
Thank you, Hero.
Any of the chairpersons have any comment on this piece?
I know we're horribly delayed. Just my 2 cents. I mean, I think Dr. Nijar's talk was really good in terms of it's the importance of physiology. Treat those lesions that need to be treated, and I think moving forward, we really need to learn how to integrate physiology with anatomy, and that I think this is really the future. Co-registration is a great tool for those labs that have it. But I mean, regardless, whether it's IFR that you have, RFR, FFR, do what needs to be done. And, I think it was just a great talk. Thank you so much.
Thank you, Aaron.
Can I ask a question, Dr. Niger?
Of course, yes.
Which modality you prefer, FFR or IFR? Because sometimes there are lesion we can assess by FFR that gives us false positive result. So in that case, how you interpret IFR?
Yes. So I will declare my bias. I am from the
you're clear.
Imperial College and we developed IFR. Our cath labs predominantly use IFR. My predominant workflow is to use IFR in most of my patients. In some patients where, for example, for either practical reasons or documentary reasons, we may end up giving adenosine and measuring a fraction flow reserve. In general, we err on the side of following the IFR. If the FFR and IFR are wildly disparate, then of course there are complex physiology reasons which I can go into to explain why there may well be disparate lesions. I will tell you that 20% of lesions within FLAIR and Sweetheart will be disparate, and remember there was no difference in the outcomes in those patients. And so although people do worry about that, in short term, 1 year and 2 year outcomes, there is not drastic differences. And we can tell that this is of value to people because all of the different companies now have made their IFR versions, and so RFR and DPFR and all these things all exist. Very, very similar to IFR. I would say that there's very little to discern between them other than their names. And so we tend to err on the caution of doing less deliberately, principally because as soon as you place a stent, you have replaced normal pathology with stent-related pathology. And I remember at 5 years, then you are likely to have had a stent-related event around 20%. And the number of patients that come back after they've been deferred from intervention is not 20%. So, I would err on the side of caution.
Thank you, Dr. Nijar. I am Professor Fazlur Rahman. I am the first one to contact with you. Anyway, there is some communication gap. I lost you, but we are lucky enough to get you with us in this seminar. So thank you. Thank you very much. Thank you.
Thank you very much for the invitation. I appreciate it.
Okay, thank you very much, Najan. Now I am requesting, I see Dr. Imad is there, but I am requesting Dr. Shirish Ahmed because he was ready actually. He was the past president of CSI, Cardiovascular Society of India, and he was also a governor of National International Council in India 2004 to 2006. Right now, he's working as a director at the Ruby Hall, Pune. Dr. Shirish Ahmed, can you hear me?
Yes.
Yes, can you share your slide and give
Yes.
a talk? Okay.
For your talk, Dr. Shri Siramat,
Yes,
salam,
Dr.
salam
Dr.
to you. You are my mentor. I am get training in Pune Hospital. So you are really my mentor. So thank you very much to join with us in this seminar. Thank you very much.
Thank you for the invitation, Dr. Fazlur. So we are going to be talking on whether to use two stents versus single stent strategy, which is a provisional stent strategy. I think things have advanced so much that I'll show you a couple of cases where we have to debate whether it should be two stents or three stent strategy. Like the case on the left, you have LAD here, we have a ramus, and we have a dominant circumflex. Same story on this side, LAD, ramus, and the dominant circumflex. However, FFR on this is negative and FFR here is positive. So when you think of doing these cases on the left side, where FFR is positive in a dominant circumflex, I would probably feel that we put 1, 2, and 3 stents and thus end up with this 3-stent strategy. While in this case, the FFR in the circumflex, which is again a reasonably big vessel, is negative, we would try and limit our stent number to just 2 stents strategy. The world is changing very rapidly, and this area of left main bifurcation, I think there is a lot of controversy, a lot of discussion, and people tend to do whatever they have been comfortable with, and of course taking assessment with the imaging as well as physiology. So this is how we ended up in this case, who had a positive FFR in the circumflex. The first stent was in LAD, was done as DK crush. Second one was done as mini crush, and then the main stent was dilated. In the other case, where FFR was negative in the circumflex, we put first stent from left main to LAD, did a pot, wired the ramus, and then brought this stent and deployed as tap technique. In tap, you know that a part of the stent is protruding back into the main vessel. So when you do a tap and you want to do the pot on this portion, you have to be careful that you don't bring the balloon to hurt the protruding portion of the stent. So this is how these two cases, looking quite similar, ended up just because the FFR was negative and positive in these two cases. With growing experience, increasing complexity, newer devices and imaging, and the patients are living longer and showing a lot of reluctance for CABG, there is every reason why we should be able to offer angioplasty. In our hospital, this is my personal data, sizable number of cases, 293 left mains. And we can see here that the total mortality is 3.7, total repeat revascularization was 3.6, half going for surgery, half going for angioplasty. So overall, the number of left mains are clearly growing in our cath lab. So let's discuss which are the cases where we do a two-stent strategy by choice. And here is a case where we have left main, in addition, an important lesion in the LAD, and a very dominant circumflex, as you can see here. So this is the LAD requiring a long stent and a dominant circumflex that you can see here on the left side. So in this case, this patient had a short duration of angina. You can see a lot of calcium on this vessel. So we did IVUS, and based on IVUS, we did rotablator to LAD, and then we put multiple stents. And this stent bifurcation was used, placed as a decay crush technique, all where good diameter stent stretch fully and the patient is doing well. So this decay crush is helping this patient extremely well following a rotablator to LAD. So this is one situation where your left circumflex is dominant. You would put two stents preferably. What about the pinch on the LCX, which is most of the time a side branch? Like in this case, you can see the primary lesion is in the LAD, including LAD ostium. The circumflex is dominant, no doubt. And you can see a big distality and long circulation controlled by the circumflex. So here again, we do FFR to circumflex at the beginning. It was negative. And we do IVUS and then do stent from left main to LAD. This is a pot which I think is a must for every case to oppose the stent to the vessel wall. After doing pot, you again wire the circumflex because this is what this position of circumflex. So you can see that the circumflex mouth is critically narrowed. Many would say that let's do FFR to check, but in a dominant situation, I feel we should put in a stent. So the option here is doing a tap here or doing a culotte. In this particular case, we did a culotte, and then you can see good flows in both these circulation. So whenever the circulation is very large, very important, I think this side branch becomes very important. And as in this case, where originally the ostium of the circumflex was normal, FFR was normal, we still had to put in a stent after putting left main to LAD stent because the circumflex side branch was pinched. Now, what about lesions at the ostium of the circumflex and ostium of the LAD? Like in this case, you can see here the left main at the distality is showing a clear narrowing. In addition, the way the two vessels are going, the mouth of LAD and mouth of circumflex is critically narrowed. In this case also, unless you have a plan to put two stents, putting in a stent later can be quite a challenge. So we settled for a cutting balloon on both these vessels and then put the first stent source circumflex and then do a culotte with the second stent going from left main to LAD and doing a final case. So it all depends on how narrow are your ostium of the LAD and the circumflex. What about the narrow angle between the LAD and circumflex? Like in this case, the OM actually is taking care of the entire circumflex circulation. And you can see a very narrow angle. And in this case, if you put one stent here first, without doing anything to the side branch, I think we would probably struggle a lot. So here, if the angle is narrow, vessels sort of diameter is matching to each other, we chose a culottes and ended up with a good results. Now I'm going to show you a few cases done a few months earlier. Like in this case, the stent was placed from left main to LAD in an outside hospital 14 months back. And this patient has come with effort angina, progressive, for the last 6 to 8 months. And you can see the ostium of circumflex is critically narrowed. Again, a very dominant looking circulation. So here, there is only one stent placed by the first operator from left main to LAD. There was a little bit of narrowing at the mouth of circumflex, but he felt it's okay to leave. And this is what happens in next few months' time, and patient has severe angina. So we do IVUS, and the LAD stent also is not very well expanded. So it's not just a requirement to do the circumflex ostium, but we need to redo the LAD. So we call this as a delayed culottes. This yellow one is the first stent placed 14 months back. We put one more stent towards circumflex because this was a large circulation. So this is a delayed culottes because first stent is 14 months old and now we are doing this. Having done that, we put one more stent towards LAD as it showed that the left main LAD stent placed earlier was not well opposed. So we call it as a delayed double culotte. That means first culotte was with the old stent and the second culotte, double one, is between the green and the orange stents. And this is how this patient had a nice result. Again, I want you to understand the importance of this circumflex. You can see it here and you can see it here. It's a very, very dominant circulation. So all dominant circulation cannot leave pinching of the side branch as not important. This is how we started and this is how we ended with a delayed double culotte. Now, this is again a case which is the side branch is not addressed. The stent was placed from left main to LAD. So this is actually an ISR which is hitting the mouth of the circumflex. Again, you can make out the circumflex is a dominant circulation and patient had crippling angina 6 months after the main stent. Main stent looks open. However, there was this lesion in the circumflex. So we had an option of putting T-stent, a tap technique here, or doing a culottes with the old stent. Whenever there is an ostial narrowing, we always like to use a cutting balloon to get a good stent expansion. So cutting balloon is done, stent is placed from left main to circumflex. A pot is done, kissing is done, and this is the final result. So we have done a culottes again with the old stent. The old stent was going towards the LAD, and the fresh stent is placed towards circumflex. So this is how we started, and this is how we ended with a delayed culottes. In this case, a similar case, this is how the index procedure, the operator ended. This was done again in an outside hospital. But anything at the mouth of the important circumflex, you can see how big is the circumflex circulation. The operator felt it's okay to leave, and within 2 months' time, the patient has come back. The entire left circulation is filling up through collaterals from LAD. There is nothing going forward from the left main to circumflex. So in this case, we used Sasuke. In Sasuke, the main branch vessel goes from here, and there is a side hole through which you can actually place the side branch. You can see the Sasuke is directed towards LAD, and the side branch is actually, side hole is allowing the access to the side branch. So we then had 2 wires, one in the OM and one in the circumflex, and then did a tap in this particular case. In the previous case, we had done a culottes, but here we have done a tap since the lesion was very soft. Now, we all believe that 2-stent strategy with DK crush is generally a very good strategy for bifurcation left main. And this is what we did a DK crush, and we imaged this patient, and the result looks very good. So we stopped, but within 6 months, the patient has come back, and typically, the narrowing is expected at the mouth of the circumflex. So you can see here, there is a critical narrowing. We did IVUS. Based on IVUS, we decided we'll use a drug balloon. So here we used a cutting balloon, a case stent expansion towards that side, and then a drug-eluting balloon to get this kind of result. So this worked very well. So every time there is a left main, we have to think whether the lesion is important and whether we are going to do 2 stents or 1 stent. You can see here that is the culprit for angina giving. So this was stented. And after putting a stent here, we have done a FFR towards LAD and FFR towards circumflex. So this is actually assessing the left main bifurcation. Remember that we have already stented this and there is no lesion here. And you can see the LAD and the circumflex both are positive FFR, which means we need to address this bifurcation. Will you do it with one stent or 2 stents? And my clear thinking is that we will do it with 2 stents. This is a abluminous test, which has a different technology, and the side bench surface can be accessed very easily. So we settled for a culottes. This first stent was actually stent 2, was left main to LAD, and then we put another stent left main to circumflex as culottes. And you can see on stent boost, this stent is not touching the first stent which was placed. So stent boost thus helps. You must take help of imaging of all kinds. So another high pressure inflation with a bigger diameter balloon, and you can see the stents 2 are weather posed. So in this case, the first stent was placed in LAD. We did an FFR towards LAD after this stent, FFR to circumflex after this LAD stents. Both were positive. So there was a culottes done to the left main bifurcation. Now, there are times when people do ostial stenting and these stents protrude back. Most of the time, angiographically, it is very difficult to assess. And this operator felt that he had placed a very good stent at the LAD ostium. However, patient has now come back, and now you can see the circumflex mouth is very critically narrowed at this particular point. It is better seen in this view. So the eleo-cranial view, which is a little bit unusual, but this was the best view to show. So in this case, we decide to put one more stent from left main to circumflex. We decide to go on the side of the old stent, crush this stent towards LAD. So this was crushed. Then we put one more stent, as you can see here. And so this is a new stent, and this red is the old stent to get a nice result at this point. So you need to sort of think what best can be done. So this is a case where an ostial stent is placed. And so the basic lesion was at the circumflex, and only an ostial stent is placed. And the patient has come back a few months later, 7 months later, with a narrowing at the circumflex. So this becomes a part of ISR because it is related to the stent and it is within real proximity of the stent. So then you have to decide, since it is a back protrusion of the stent, whether you are going to do a mini culottes or whether you're going to crush. In the previous stent, we crushed, but here we go through the stent and we push the stent portion, this portion, towards the roof of the left main, and then we do this. This is the final result on this case. So once you know that the stent is protruding, you can make your choice. This is also a circumflex stent placed, and we wanted to go through the stent to a lesion in the distal portion. This was almost a 7-year-old stent. And now he has come with a narrowing at the mouth of the LAD and another lesion in the distal LAD. So in this case, again, you can see on stent boost. So take help of everything that you have. So we intentionally placed our wire through the back end of the stent. Stent boost clearly shows that we have gone through the back end of the stent. So we pushed this protruding portion to the roof and did a culottes with the new stents. And this is the final result. In this particular case, we used an OPN balloon, which all of you know is a 2-layered balloon and can take very high pressure. We also use a drug-coated balloon on the circumflex, which was working well. But since it was an old stent and we had to touch this with a balloon, we thought it's safer to use a drug-coated balloon. So in this abluminous disc, the coating is on the one side. The side branch axis is well preserved, and the balloon actually also has some coating. There is an edge coating on this balloon. So when you expand the stent, a drug is released at the distality very well. So this is how you can sort of get help. In this previous case, we wanted to put this stent distal to the old stent. This is an old stent. And we had a lot of difficulty. So a few months after this stent was placed, we thought we'll check why it was difficult. And here you can see on a CT angio the stent protruding back, and that was the reason why it was difficult. Now, we always have to think whether a stent at the left main bifurcation area, it can be one stent, it can be two stents, or it can be zero stent. In this particular case, strong positive stress test, LAD, stented here. But you can see the circumflex. It had two important branches. It had an important narrowing. Now, none of these branches are matching the diameter of the left main. So we were wondering how to do this. If you stent only the ostium in downwards, I think the possibility of restenosis is very high. So we have sort of moved away from stenting only the ostium, always bring the stent back to the main vessel. This was a magnified view, and luckily for us, both these branches had an FFR which was 0.93. So we decided we have stented LAD, we will not do anything to this circumflex A. It had a disparity between these. And again, if our stent going to this branch can pinch this branch because this ostium was diseased and vice versa. So we were quite happy to leave him with medical treatment. Now this is almost a 6 years follow-up. In 2014, you can see the left main trifurcation has some disease, but all were sort of 50 to 60%. Stress test was quite impressively positive, and that's why angiogram was done. But because these lesions were considered not important, patient was kept on medical treatment. At this stage, a few months later, I think we acquired FFR, and we did an FFR to this patient. So the both LAD going here and circumflex going here both had a negative FFR. So we are quite confident that our decision to stay on medical treatment is good. But only 1 year has passed, and how long this will hold true that the lesion will not advance. So now we are with non-invasive testing, stress thallium, which is only mildly positive. And unless it is more than 10% positivity, you can safely conserve it. So in 2020, that's 6 years after the first angiogram, patient continues to be on medical treatment. So to end, finally, when we talk of left main bifurcation, trifurcation, we can even put 3 stents if there is a true trifurcation, all important branches and all deserve an ostial addressing because of a criticality. When we talk of 2 stents versus 1 stent, what is generally considered as provisional, now this is not a technique, this is a strategy. So when we talk of this, always give priority to this. So 1 stent is a priority in my thinking, and I guess in everybody's thinking, instead of putting 2 stents. So wherever possible, avoid putting 2 stents. But there is no these days for putting 2 stents. And I would certainly revert to 2 stent strategy at the left main bifurcation whenever we have a dominant circumflex, so don't ignore dominant circumflex. I showed you lots of cases which had important circumflex narrowing. If there is an osteal disease both in LAD and LCX to begin with, I think there is no way your provisional strategy is going to work. If the angle between LAD and circumflex is going to be narrow, again, it's safer to go with a planned two-stent strategy. If there's an ISR at the circumflex from a previously placed LAD left main stent done as provisional, I think again you need to put a second stent. And if there is a significant pinching of the side branch circumflex, you will again need to put two-stent strategy. With this, I will stop. Thank you for the invitation. And if we have time, maybe we'll take questions. But I personally feel that one need not shy from doing two stents or three-stent strategy. There are very good quality stents, choose stents with the thicker struts, which can allow you a good side branch access, but always end up with a good bifurcation case. So use adequate size balloon, always do a final part, and this is how you can get good long-term results. As you saw, our 10 years follow-up had just around 3% repeat revascularization incidence, which I feel is not bad. So it's a clearly emphasis leaning towards multiple stent and multiple stent. Thank you indeed for the invitation.
Okay, thank you, Dr. Shiresh Iramet, for your brilliant presentation. Actually, now I am actually requesting Dr. Imad Shivan. He is in waiting for the cues because he has another commitment for the other program in Egypt. So, Dr. Emmanuel Ako, can you give a talk just after Imad Shivan because he is in another session commitment in Egypt?
I'm sure. I'm just about to start a case, but yes, he can go ahead.
Okay. Thank you very much, Dr. Emmanuel Ako, because your topic is very interesting for our daily practice. So we are considering your talk is very, very elegant and it is really helpful for us. So I am requesting before you talk, because Dr. Imad Shivan have to leave another session in Cairo, Egypt. That's why I am requesting Dr. Shivan. He has only 15 minutes time so that he can give his talk. Okay, Dr. Shivan.
Thank you.
Can you hear me? Dr. Shivan? Dr. Shivan? Dr. Imad Shivan, can you hear me?
Yes.
Okay. Okay, thank you very much. Dr. Imad Shivan, actually, he's very busy with today. There are a lot of conferences he have to attend. Already he attended 2 sessions and this is our 3rd session, and after that he will join another session. So I just give him this opportunity to give his talk right now because he has some time constraint. That's why I am requesting Dr. Imad Shivan. He is Bangladesh Friendly Intervention Cardiologist. He is the Director Cath Lab in Petershill Hospital. He is the board member of European Bifurcation Club and he has tremendous contribution in the development of bifurcation strategy. So I am requesting Dr. Imad Shivan to give his talk, Philosophy of Provisional Strategy in Left Main Disease, What, Why, for Whom. Thank you very much. Dr. Imad Shivan, can you continue your talk?
Thank you. Thank you very much. Thank you for the invitation. I'm really happy to join this webinar. Actually, discussing every time is very useful for all of us. However, I'll try to go through the bifurcation treatment in general, then going for provisional. What is important, the first step for me, for any bifurcation, not only left main, I think the clinical relevance of side branch is the first thing to evaluate. That means if you don't have a relevant side branch, you can leave it just open. You should not do any other thing.
clinical relevance of side branch in bifurcation, we do not have confirmed criteria to evaluate its clinical relevance. However, we have some data to share and to be based on to know about something about the relevance of side branch. This is a study coming from many years back, but showing that if the vessel is covering more than 12% of left ventricular myocardium, this will have prognostic significance. That means it's clinically relevant for the patient. And this is also mentioned in the European Society of Cardiology guidelines for myocardial revascularization 2018, that large area of ischemia detected functional testing more than 10% of left ventricular myocardium or abnormal invasive FFR should, in this vessel, is prognostic for the patient, so has a clinical relevance. From angiographic point of view, we do not have that much criteria, but we have some data coming from myocardial segmentation techniques done with CT scan. And these studies were able to show that a vessel that have a length more than 73 millimeters, let's say 75 millimeters, will be covering 10 or more % of the myocardium of left ventricle. So we have now some data, and based on this, I can show you some example like this. You see this is very big diagonal, very long diagonal. Size is over 2.5, and of course this good vessel, prognostically important for the patient, if needed, should be treated. While this one also, again, you can see here, this is covering a large amount of myocardium. And what if you lose it? You can see also that ECG patient will have ST elevation. That means severe ischemia, and of course should be recovered. And as soon as you recover this, then everything will be in place. So this is what's important. Now, coming to left main, I think this problem is not there, doesn't exist, because we are not dealing with a small vessel. We have main vessel coming from the bifurcation of distal left main. So every time you have a significant vessel when you are treating distal left main. And you see how large is the area, which is covering mostly, I mean, at least in each patient will have a good coverage or good amount of left ventricular myocardium covered by circumflex. So in distal left main, the side branch, what we consider side branch as circumflex, is relevant and should be taken care of about. Now, you see here we have different kinds of bifurcation or distal left main disease. And the second step, which approach, when you see this kind of lesion, which approach, simple or complex? That means provisional or another two stents technique. Well, we do not have even classification that can guide us, because of course we have Medina classification, but if you look on Medina classification, is very good, excellent, and simple for defining the plaque distribution, but we do not have any information about characteristic and severity of the lesion. We don't have about the size of side branch and length of lesion side branch. We don't know from this classification the angle, whether it's calcified, tortuosity, thrombus, or so on. So I think it is not adequate to choose or to select your strategy. This is very recent proposal for another classification, ABCD classification, published by Mamas, and I think same. Some lake is there. We have something about diameter, but we do not have nothing about how long the lesion, calcification, the angle, and so on. So just to give you an idea, I mean, we have here Medina 111 in both these patients, but you all will agree with me that the strategy can be completely different from this to this. And same here, the anatomy. When you have multiple bifurcation, this can also change your strategy, as well as extreme angulation of the circumflex can change your strategy, as well as diffusion of disease on circumflex can change your strategy. But what is very important is you see here that this is a study, a failed 2 study, showing that the outcome, there is no difference in outcome between single stent and double stent in distal left main. However, the difference is coming, even if it's not significant, but if you shift from provisional stenting, that means you plan for provisional stenting, but something will happen during your procedure, and you shift for 2-stent technique, then shifting for provisional 2-stent technique will be associated with more MACE. So it is very important to select the appropriate strategy from the beginning and not shifting from one to another. Now, of course, we have different scenarios in distal left main. Not all are born equal, of course. So every time, based on the information I have explained before, now 1 or 2 strategy is depending on size of the vessel, the length and distribution. That means the clinical relevance, but this in distal left main doesn't count. Lesion severity and lesion length on the side branch, and anatomical complexity of side branch, that means in this case circumflex. Disease extension, multiple bifurcation, angle, calcification. So operator experience in performing and optimizing any bifurcation approach is relevant, as well as the specific technique selection. So if you are selecting your technique appropriately, this is at least 50% of the job is done. Now, many approaches, of course, we have provisional and 2 stents and multiple 2 stents strategies that have been before, but that provisional philosophy is based on the following principle: to keep it simple when it's possible, to limit the number of stents at the carina, because we know that if you increase number of stents, you will increase MACE. That is no discussion about this. Good apposition. Of course, you should do your best in order to optimize, even if you are doing single stenting, but you should respect the anatomy and function of the bifurcation. It is not only strategy. I think it is also an approach, it's technique. And I will go through in this to show you step by step how to do provisional stenting. Of course, provisional stenting, every time anything can happen, guarantee a second option if needed. And this is another safety point that to keep in mind. And of course, from studies, we know that provisional stenting also in distal left main is associated with good clinical outcome. Of course, in the procedure, I mean, intracoronary imaging and physiology can help also in provisional stenting, in planning your strategy, in optimizing your strategy as well, and in guiding your strategy. Now, technical issues, of course, like something like this, if you go with IOS and see you do not have any involvement of the ostium, both ostium, even if trifurcation, you can make it very simple. Just place your stent at the carina. You might protrude a bit at the carina, but you leave both ostium free, and this is possible. And this is what we are doing in this kind of lesions. But of course, you should be sure that you are not leaving too much plaque on one or the other branch. In in provisional stenting, I think it is very important, and we have learned a lot when we learned about the anatomy and the characteristics of the lesion. That means in the diameters, that means the sizes, in proximal bifurcation is different than distal bifurcation. Then this anatomy is functionally important, so you must keep this anatomy and respect this anatomy and keep the function as it is in the beginning. And for this, the proximal optimization technique have been introduced in order to have a good apposition of the stent, respecting the anatomy of the bifurcation, as you can see here. While if you are putting an oversized stent in distal bifurcation, the distal segment of main vessel in bifurcation, you will have some compromise of some pinch on the side branch, which might be carina shifting or plaque shifting, whatever, and you cannot leave it like that. So going now just step by step in provisional stenting, wiring both, pre-dilating. Lesion preparation is very important because in order to obtain optimized result, you have to prepare your lesion before, particularly if you have some calcified lesion, then cutting balloons, scoring, lithotripsy, and rotablation, whatever needed, you should prepare your lesion before stenting. The stent is the last thing to do before you should prepare very carefully your lesion. Then after this, after stenting, part, if no compromise, the proximal part you are putting here, if no compromise on side branch, no chest pain, no ECG ischemia, TIMI flow in side branch is 3, I think your procedure can be considered finished. If you don't have any compromise on side branch, you do not have to cross or to do kissing balloon or whatever. It's okay like this. If side branch is compromised, that means you have something going wrong. Then you have to change wire. That means exchange the wire from main vessel going to side branch, and you should try to cross distally, as we have learned from bench testing that crossing distally will give you much more optimization of the placement of the stent, particularly at the ostium of side branch. And then the wire from side branch going to the was jailed in side branch will go to main vessel. And after this, you can do kissing balloon, and after kissing balloon again report, and this will be your final result. This is what is the strategy, what is the technique to do provisional stenting today. It's not simply go and put one stent and it's like this. Now, something can happen, of course, as we have seen before, and also this after crossover stenting from distal from left main to LAD. You see some pinching here. We went with the FFR. You see 0.80. After with small balloon, that means undersized to the circumflex diameter. We inflated the balloon. This was the result after balloon inflation, and this was FFR after balloon. And patient was kept like this, with no stenting, with no other unnecessary stenting. Alternative to kissing balloon, we know today pot, if you don't have any compromise, is okay. If you have some compromise, you can go with side branch balloon. But if it is not, every time you are crossing the stent with balloon, then you might induce some deformation of the stent. So after this, go with pot. Or somebody prefer to do this instead of regularly, we do pot, side branch, repot. I don't know which alternative is better, but I think, again, if it is simple, keep it simple. That means if you are doing POT and see you don't have any necessity to do any other thing on side branch, keep it like this. Also in distal left main, like this. Now, I don't want to go through many studies, but I think this is very recent multi-analysis, single stenting versus two stent in bifurcation lesion, and showing that there is no difference, no significant difference in terms of MACE, in terms of myocardial infarction, target lesion revascularization, and stent thrombosis. What is amazing, that mortality is reduced by 31% in patients who are receiving single stent. And, And this is coming from at 10 years follow-up from our group. And you can see here that single stent is still favored over two stents in terms of less thrombosis, less total MACE, even at 10 years. Now, going for another recent meta-analysis, taking consideration multiple techniques, crush, culotte, DK crush, T and tap, and comparing this to provisional, you see that all two stents techniques except DK crush are not doing better than provisional stenting. The only one is DK crush, but we all know that DK crush series is taking consideration every time long lesion on side branching, more than 15 millimeters in all DK crush series studies. So that means taking consideration complex bifurcation, not simple bifurcation. So, and the consideration from this, the conclusion from meta-analysis, that the benefit of two stents technique was observed in bifurcation lesion with side branch length more than 10 millimeters. That means with long lesion, not with focal lesion. And no differences were found in cardiac death, myocardial infarction, or stent thrombosis among analyzed techniques. That means all techniques will have the same frequency of stent thrombosis and myocardial infarction. From trials and registries, so simple stenting should be the default strategy when it's feasible. Complex stenting, two stents approach is the default strategy in complex bifurcation. But what is lacking is that we do not have a definition with what is complex and what is simple. And this is what we have to work on in the future. Well, something have been done by definition study, one study. That means some criteria were there to define what is simple and what's complex. Measure criteria were the severity of the lesion and the length of the lesion of side branch. And I think this is the main factor. And other minor criteria like multiple bifurcation, thrombus, and so on, criteria on side branch. When you have one major criteria and two minor criteria, this is considered complex, and then otherwise it is simple. And look on the outcome. If you are approaching simple bifurcation by provisional stenting, then provisional stenting is better than two stents. But when you are approaching complex bifurcation with provisional stenting will do worse than two stents. That means we should know that complex bifurcation should be treated with two stents as default strategy, and provisional should be kept for simple bifurcation. And this is true for just 1 minute. This is what's confirmed also in definition 2 trials. So in my conclusion, I would say like this: clinically relevant side branch, and this is the case of left main. You should keep open side branch in non-left main bifurcation. If you have simple bifurcation, then go for elective simple stenting. If you have complex bifurcation, go for elective two-stent technique. And this is what I consider today the modern approach for bifurcation. Whatever strategy you are using, what proposed very recently in the last American Journal of Cardiovascular College of Cardiology Intervention, and by Park. And what he is calling IBSP strategy, that means lesion inspection by intravascular imaging. Plan your strategy based on inspection of the lesion by intravascular imaging before, pre-dilatation, prepare your lesion preparation, stenting, that means choose your stent, the length, the size accordingly to intravascular imaging, and then optimization by intravascular imaging. This is what is the modern approach to any strategy, to any technique in bifurcation today. Thank you very much for your attention.
Thank you, Shiban, for your brilliant presentation. I think you are in very harsh. So now there are some time constraints. We have to reschedule our program. So in our first talk was actually we are related. Now I think I can request Professor Jamal, can you give your talk and can you share your slide for brief and small, and as a time constraint you should try to customize your presentation. Thank you very much.
Thank you very much.
Hi, good evening. Can you hear me and see my slides?
I think you also in busy. Thank you very much. Okay, you can continue your slide. Okay, thank you very much.
Thank you very much for.
Because it is very exciting session. That's why we are waiting for chronic coronary syndrome. Okay, thank you.
I just
say a few words regarding you, Emmanuel. He is the consultant cardiologist. He's a Brompton Hospital. He is a very master of complex PCI. So I am requesting Dr. Emmanuel Iko, please can you continue your slide?
Okay, thank you very much for the invitation to the society and to Dr. Selban for his excellent talk and for all the talks that have gone before. I think everyone who's watching and learning, these are really useful tips and tricks to pick out when you're starting or even when you're experienced. I've learned a lot from a lot of the talks this morning. I visited Bangladesh a couple of times. I've seen the keenness in terms of coronary intervention. My talk is really about PCI in chronic coronary syndromes, which is the new terminology for stable angina, and the fact that we really shouldn't forget the medical therapy arm of this. We've seen lots of techniques, interventions that we apply to patients, but it's also just stressing the importance of the medication. My objectives are really just to talk about the shifting paradigm in chronic coronary syndromes, just mention some of the key trials where optimal medical therapy and PCIs have been used, and then how we decide when we see patients with angina. So the latest guidelines for chronic coronary syndromes is the ESC, produced in 2019. They've actually given 6 clinical scenarios for patients with symptoms of angina. The one that's been included, which we probably know that when we see patients and do coronary angiography, up to about 50% of patients will have anatomically normal angiography, but that doesn't mean they don't have some coronary dysfunction. And this could be vasospastic or microvascular angina in nature. And I think the ESC guidelines in 2019 particularly addresses these groups of patients. As always, when we're looking at guidelines, we look at the level of evidence, level A being the best, and this is from randomized controlled studies or meta-analyses, and then the class, with class 1 being the best, highly recommended or indicated, and class 3 not recommended. So cardiovascular disease, as we're coming to the end of this seminar, we know is huge. Globally, over 17 million people die every year. Greater than 75% of these are in low and middle income countries. And in Bangladesh, the figures are not dissimilar. So about 30% of cardiovascular death and this is projected to increase as a result of coronary artery disease, and the majority of deaths are non-communicable diseases. So really, this is something that affects all of us in developing and developed countries, and we've learned lessons from a lot of the procedures that we can do to help them. The risk factors we know about, they're the non-modifiable risk factors such as age, gender, history, ethnicity, and then key modifiable risk factors such as smoking, cholesterol, hypertension, diabetes, lack of exercise. And particularly in Bangladesh, and these are figures from the WHO, tobacco smoking is on the decline, but is a key risk factor which we should address, as well as our very highly technical, complex coronary intervention, addressing obesity and getting people to be more active, and targeting blood pressure treatment. So as well as a very high-tech, physiology-guided, imaging-guided procedure which we use, using all the techniques available to make our intervention optimal, we should not forget these risk factors in patients. The pathophysiology is a slippery slope, atheroma formation in the wall of the vessel, and this is a key to understanding how we treat patients. In terms of angina itself, this is dated back to the 1700s when William Herberdin described this sensation of a strangulation or anxiety when someone's walking up inclines and is relieved by rest or GTN spray. So again, the history taking here is very important. Before we do an intervention, we should really understand the patient's symptoms, because what we're trying to do is remove the patient's symptoms first and foremost so that they are able to improve their quality of life. The classification, typical angina, has all those three factors in it. So they have the chest discomfort, characteristic and quality provoked by exertion or emotion, and is relieved by rest or GTN spray. If you have all three, it is a classic history of angina. If you have 2 out of 3 of these, it's atypical angina. And if you have one or none of this, it's non-cardiac sounding chest pain. So I think that's very important when, first of all, taking the history. We are very familiar with angina symptoms, patients having the crushing central chest pain, and the angiogram image on the left has 3 vessel disease, so very significant coronary artery disease. As interventional cardiologists, we are very aware of this type of patient. The patient we're not very aware about are those who have normal coronary artery, the so-called INOCA patients, who have very descriptive symptoms of chest pains, but still have unobstructed coronary artery. And this points more to a microvascular dysfunction. And patients may have a combination of the two, of micro and macrovascular. So in terms of the prognosis, as we've heard, it's not a benign condition. There is about a 4% annual mortality with chronic coronary syndromes. And this dates back to the Framingham study in the 1990s down to the most recent REACH study in 2010. Each year, patients are followed up and the mortality is roughly about 3 to 4% if you have a diagnosis of coronary syndrome. So this is not benign, and we really should focus on their management. The diagnostic testing varies from CT coronary angiogram, if we suspect that the patient has a low risk, to invasive coronary angiography with pressure wire study, and this could be FFR or IFR or CT-FFR, whichever is available in your unit. But it's really important, the goal of treatment for chronic coronary syndrome, and I can't stress this enough, is to improve the survival and reduce cardiovascular events. But also importantly, we want to remove these symptoms of angina and improve quality of life. So whenever we look at trials, even though the endpoint may say that survival is not reached or there's no reduction in cardiovascular event, we notice that there is improvement in symptoms or quality of life. And that is equally important because these are the goals of what we do to treat our patients. The management should consist of lifestyle changes and patient education. If they smoke, to stop, antiplatelet therapy, statins, ACE inhibitors, diabetic drugs, which are now coming online with your SGLT2 inhibitors, is really a drug we should get in very early in patients to improve cardiovascular outcome. In the COMPASS study, we've heard of rivaroxaban 2.5 with aspirin, reducing antithrombotic events. And then anti-anginals plus or minus revascularization should come later after we've done the disease-modifying aspects to the treatment. We can have a combination of anti-anginal therapy, beta blockers, ACE inhibitors, ranolazine, some of the newer drugs, to be able to address some of patients' symptoms. And if that fails, we then move on to revascularization. And that revascularization after drug therapy can include PCI, coronary artery bypass graft, and if they continue to have symptoms, we increase the anti-anginals or repeat revascularization, as we've heard in a lot of the techniques. Pre the COURAGE trials, this is a meta-analysis of 11 randomized control studies looking at medical therapy in patients. And I think what this tells us is that medical therapy works. So if we give patients optimal medical therapy, we can actually impact their death, cardiovascular outcome, and non-fatal MI. So this is pre our drug-eluting stents. All our very good, useful FFR-guided, IFR-guided techniques show that medical therapy really should be a foundation in treating patients with chronic coronary syndrome. We then had the COURAGE study in 2007, which as interventionists, we scratched our heads and wondered why adding PCI to optimal medical therapy didn't make much difference. But this suggests again that optimal medical therapy in the long-term follow-up is also very effective. But this doesn't mean that we shouldn't use PCI in these sets of patients. More recently, 2017, my colleague here at Imperial, Dr. Al-Lami, in the Orbital study, which you may have heard of, small study with 200 patients. This was the first randomized placebo-controlled PCI study anywhere in the world. So the patient was randomized either to have a placebo, which means they would have the angiogram, but no intervention. The patients will have a headset on and they didn't know if they had any procedures, or they had a PCI. And there was no difference at 6 weeks, significant difference between the PCI group and the sham PCI group at exercise. So this is also informs us that there is some element of placebo-controlled or placebo effect when we treat patients with stenting. This placebo effect is useful because it takes away patient symptoms, and we shouldn't underestimate that fact. But it should mean that when we are doing a PCI, we really should do the best PCI we can using physiology and also using imaging to get the best long-term results. No doubt you've heard of the ischemia trial, which is one of the largest studies ever conducted, over $100 million over 10 years. But this is looking at patients who had stable chronic coronary syndromes with at least moderate ischemia on stress testing, and whether revascularization would add anything on top of optimal medical therapy. It's important that we should know that patients with left main stem were excluded, unstable angina, recent PCI, or if you had an ejection fraction of less than 35%. So we can't extrapolate these results of the ischemia trial to our patients if they have these risk factors. Again, the primary outcome of cardiovascular death showed no difference between the PCI versus optimal medical therapy arm. There was an increase in non-fatal MI after in the PCI group, but this seemed to be balanced out later on by the PCI group not having as many non-fatal MIs as a conservative group. But overall, over a 3.3-year follow-up, there was no difference in both arms. So the conclusion of the study was the primary endpoint of cardiovascular death, MI, hospitalization for unstable angina, and heart failure was the same in both arms. What, however, it did show is that there was an expected angina relief and quality of life improvement in the invasive arm compared to the conservative medical management arm. So in summary, from 1999 up to 2019, we're still trying to get the mortality and preventing MI benefit of PCI. However, we see, and this is very important, that PCI relieves angina and improves quality of lives. And these are very important. In the last 4 studies, really, in the recent age of modern PCI, in terms of bare metal stent, suggest that there is benefit to have PCI in patients who have symptoms of angina. There is a special mention for treatment of elderly patients, and these are patients over the age of 75. They are at increased risk of morbidity and mortality. We should, wherever possible, use drug-eluting stents and use radial access in these patients, and consider their frailty or the frailty score when we're assessing them for PCI. So I think the overriding factor is that, again, the treatment should improve survival and reduce cardiovascular events, improve symptoms and quality of life, which I think a combination of medical therapy and PCI offer patients. So the take-home message is always we should aim for symptom control in patients who present to us for intervention. So in summary, optimal medical therapy is very effective. PCI is safe and very effective at symptom relief. And also the strategy should be complementary and it's not one against the other. and we should remember that the patient came to us with symptoms, and that's what we're trying to relieve. And thank you very much for inviting me to give this talk. I hope I've made up some time. Thank you very much.
Can I say a question, please?
Please, yes.
To Emmanuel Leke.
Hello, hi.
Thanks. Thank you for a nice presentation. Actually, I want to know about the in case of microvascular disease. Suppose coronary sinus filling time is a very important novel method of detection of microvascular angina. So actually, any cutoff value of time. And another question is, you have actually about SGLT2 inhibitor in case of chronic coronary syndrome without diabetes. I know with the latest guideline, also, but current guidelines. But any in your experience, actually, already you have started and you have even in your experience. I want to know the two questions actually.
So those are two very good questions. I'll start with the second one in terms of diabetes in patients with chronic coronary syndrome. We've seen the SGLT2 trials. We've seen dapagliflozin. We've seen the EMPA study, the EMPA-REG, canagliflozin study. All show that adding SGLT2 to patients who've either had risk factors, and that's smoking, diabetes, hypertension, or they've had a coronary event in the past, really significantly reduces their cardiovascular event. So in my practice, if I see a diabetic patient who has risk factors, I would start them on dapagliflozin 10 milligrams. If they've had a cardiovascular event, I will put them on empagliflozin to reduce those events. So yes, SGLT2 is very important in diabetic patients. We also see that DAPA-HF, SGLT2 reduces the risks of heart failure developing in patients with type 2 diabetes. So a very good drug. With regards to microvascular angina and using coronary flow reserve, we do that in the cath labs, and a value of less than 2 is the value that we take to mean that there is microvascular dysfunction. So if we do your coronary flow reserve and that's less than 2, that suggests that there is some degree of microvascular dysfunction. And then we really go towards optimizing on medical therapy, endothelial dysfunction type medical therapy with statins, things
actually,
like
my question is coronary sinus filling time. This is
coronary sinus filling time. Sorry,
time. Suppose in our cath lab we have on a study we have done, that is our cutoff value. We have seen that 0.94 second. If more than 0.94 second, it may be considered as microvascular angina or dysfunction. But less than this cutoff value, this is but actually any recommended guideline do not actually mention any kind of recommendation like this. For that reason, even in Mayo Clinic, there is no recommendation.
That's very correct. But I think we have similar values to yours where we see there is some correlation, particularly with coronary flow reserve. So yes, similar values. Mostly our method of analysis is using coronary flow reserve for microvascular studies, but I've seen similar data that suggest the numbers you've mentioned may indicate the approximation, a bit like IFR and the FFR. But yes, very similar values. But I think most guidelines have stopped short of mentioning cutoff values because it's still in the experimental stage. So I think they're still trying to work out what the best optimal number is, because as you know, that number will always be adjusted to be able to get maximum number of patients into that group.
Thank you.
Thank you very much, Dr. Emmanuel, for your brilliant presentation. Actually now we are very close to our session. Now I am requesting our Professor Mir Jamaluddin sir. He is the director and he is the Secretary General of Bangladesh Society of Cardiovascular Intervention, and he and our President Fazlur Rahman sir, Fazlur Rahman sir and Mir Jamal sir, especially they should appreciated by their wonderful effort from dialogue programs. So due to time constraint, we are not trying to lingering the session. Now I am requesting Professor Mir Jamaluddin sir to continue his talk. After talk, our exciting case presentation, very, very exciting case presentation from Bharat Purohit. So I think you should enjoy the case. Now, Professor Mir Jamaluddin sir, can you sir share your slide?
Let's look at that ourselves. landscape, how to select best option. At dead of night, we are starting in a topics most basic. The superior topics has been completed, but the basic topics, here I have started at mid. Done. We know the incidence of left main diseases, approximately 5% of all undergoing coronary angiogram are more frequent in women associated with three vessel disease in appropriate of the case, and left main stenosis treated only medically have a 3-year mortality rate up to 50%. And here we see the anatomical scenario, case scenario. This is on the left panel, and this is critical ostial left main stenosis, and second one, that is bifurcation left main stenosis, including the origin of the left anterior descending artery. And this is the third one, there is bifurcation left main disease, and you here see the left circumflex is bigger than that of the left anterior descending, and this left circumflex is a dominant vessel. So next, this one, another, the left main, mid left main disease with ostial LAD disease, and ostial left circumflex disease with downstream disease in the left circumflex. And downstream disease in the left circumflex, and this is another case where there is entire left main is diseased, and this is also again bifurcation left main disease with involving the both LAD and LCX. And we have to decide what are the deciding factors of LM intervention. We have to know the anatomy of the left main, position of the LMPCI in guideline studies, LM bifurcation stenting, role of imaging, IBAS, OCT, FFR. Already this has been completed by the other speakers, so I shall finish very soon. Selection of the hard wires. And this anatomy of the left main disease, ostial and mid vessel lesion up to 30% and approximately 70% distal left main disease amongst all the left main diseases. These lesions, ostial and mid vessel disease, these lesions can essentially be treated as in any other vessel be stented, with single stent strategy. And distal left main stenosis, 70% cases, we get the distal left main stenosis, and distal LM stenosis are in most cases treated as true bifurcation lesion, and restenosis rate approximately 5%, but higher in patients with distal left main disease, it is approximately 70%. And target lesion revascularization rate is around 10%, and lower rate of success but higher rate of restenosis in case of distal LM disease. And here we have known it already that ostial and body is approximately 30% and distal left main is 70%. This is a big algorithm. I do not want to go through the total algorithm. Only I want to tell that angiographically, if it is left main stenosis equal to more than 70%, we have to decide revascularization. And angiographically, when it is 30 to 69%, we have to see the FFR. And if FFR is significant, then we have to go for revascularization, and if FFR is less than more than 0.80, then we keep it optimal medical management. And the rest, the heart team approach, surgical operative risk, if there is surgical operative risk is non-prohibited, then we go to syntax score, and within syntax score high, if there is high syntax score, it is more valuable to do CABG, more effective in the CABG range, and it is low syntax score, then angioplasty should be done. And position of the LMPC in the guideline, we have already seen it. Should we treat all left main diseases? Yes. If yes, when? Then it is the older one, 2014 ESC city guideline. They have shown the left main disease with syntax score less than 22, class 1, both CABG as well as PTCA. And left main disease with syntax score 23 to 32, class 1 indication for CABG, class 2A indication for angioplasty. And left main disease with the syntax score more than 32, class 1 indication CABG, and class 3 indication is our angioplasty. And in 2018, same thing, they have also shown the left main disease with syntax score less than 22 and 23 to 32, class 1 and class 2A. And temporal trends of LM revascularization. We see that starting from the beginning, it was 25%, and gradually it has increased up to 46%, and in 2007 to 2013 it has increases up to 61% LMPCI. And if we see the maze with evolution of the stent, then we can see that downgrading from BMS to early drug-eluting stent and late drug-eluting stent, it has entered into the positive side. And previous one, that BMS is not superior, and early days is also not suitable, but late days is suitable and in favor of angioplasty. And if we see the studies, all these slides has been shown by another speaker, that is primary endpoint in different studies, syntax 10 years, pre-combat 5 years, and novel 5 years, and Excel 5 years. All they have shown approximately similar results, but some study like Excel trial, they have told that it is non-inferior angioplasty over CABG, and Nobel study, it has told that inferior CABG is superior, and in angioplasty is inferior. And if we see the left main bifurcation stenting, we see that the different types of anatomy, Medina classification. This has been also shown by the previous teacher. And for flow chart, here there is another flow chart, that is severe bifurcation lesion. Then we have to think whether 2 stent strategy or 1 stent strategy, and depending on the involvement of the vessel, left antero-descending ostium and left circumflex ostium, and beyond the circumflex ostium, that is downstream disease, and then we shall have to evaluate the angle, and if the angle is 70 or more, we usually use T stenting port, and if the angle is less, we usually like crash, mini crash, or pull out, and these are the different types, and there are different results also. We shall show later on. And factors deciding strategy for left circumflex. It is very important. Size of the LCX occluded. Don't think you go straight for a professional strategy. And if it is less than 2.5 millimeter, protection wire is sufficient. And if it is large, then you analyze the plaque distribution, calcification, bifurcation angle, diameter, and LAD and LCX disease, and accordingly you will do the decision whether protection wire, balloon professional stenting, or 2 stent technique is utilized. And 1 stent better than 2 stent for left main bifurcation is shown by the different studies like Palmerian, Toyokuful, Kim, Song. Almost all of them has shown that major adverse cardiac event, in some case mortality, a myocardial infarction, target vessel revascularization, almost in favor of intervention in the left main. And here, when 2 stent techniques, professional stenting more than 70%, and 2 stent techniques approximately 30%. And professional stenting normal left circumflex, Medina 110, 100 or normal or diminutive L6, small L6 with less than 2.5 millimeter in diameter, focal diseases in distal left circumflex, meaning then downstream diseases there, and disease of the left circumflex, Medina 111, 101, here 2 stent strategies may be necessary. Large left circumflex with more than 2.5 millimeter in diameter, diseased left dominant coronary system, concomitant diffuse disease in distal left circumflex. And does design matters of the stent matters in left main PCI? Yes, we know there are different designs of the different stents. It is to be tell frankly that all the third generation stents are almost equal, but out of which them some stents they have some special value, like maintains scaffolding and coating integrity, and with over expansion. It is possible by onyx, resolute onyx, and resolute onyx in 75% of the left main diameters are 4 and 4 to 5.75, and that is why it is also a bit necessary, as because 4.5 and 5 dia stent only in the range of resolute onyx. And here you see there is a very nice round side branch axis, and this is the beneficial effect of the of taking this resolute onyx in left main disease and bifurcation disease. And resolute onyx disease demonstrated higher resistance to longitudinal stent deformation. So design also matters in some cases. And is angiography enough for diagnosis of clinical ischemia? It has also been shown there are different physiological studies like functional angioplasty. We require integrated use of IVAS and FFR. And functional angioplasty integrated use of FFR and IVAS avoid unnecessary PCI, and it has reduced the number of PCI, avoid unnecessary surgery, minimize MACE, maximize clinical outcomes, save money and saves life. And role of imaging in LMPCI, we know totality of studies and imaging to guide unprotected left main stenting PCI is unfavorable with imaging. And there are different things like visual function mismatch. If there is sometimes we see the visually 80% disease, IVAS MLA 6.2 millimeter, FFR 0.82, and treadmill test negative. This can happen. Similarly, reverse mismatch can also occur. Visual estimation 30%, but FFR is 70. IVAS MLA is 4.5 square millimeter, and stage even treadmill test is also positive. And so we shall have to think all together, including the physiological and our anatomical angiographic picture. When you use FFR more one stent, and FFR, whenever we use FFR gradually, the increasing 59.6% single stent has been increased to 66.7% single stent, meaning that double stent has been reduced from 40% to 33%. And IVAS guidance saves lives in LMPCI. It has been shown in different studies that IVAS also reduces the number of angioplasty. And IVAS, it is told that whenever we use FFR to avoid the angioplasty, to reduce the number of angioplasty, and IVAS is for doing the angioplasty with exact picture. From where shall I place the stent and the diameter of the stent, and after the procedure we can also show is there any mismatch or not. And OCT in left main PCI, same thing. It is also essential. If it is possible that in assessing stent sizing, dia, length, lesion complexity, calcification, stent apposition, and arterial wall response of days, carina shaped, plaque shaped, OCT guidance in the left main system is limited by the reduced penetration of the OCT light, including the assessment of the media to media distance to aid in stent sizing. It is very important if it is available. Let us see what are the case scenario we have seen and what we have done. And I shall have to finish it very soon. This is the first scenario, what we saw, that is the ostial lesion, and this ostial lesion we have done angioplasty with single stent strategy, and starting from the ostium of the left, and this you see IVAS pre, and left main is 2.29 millimeter, and so it is very much essential to do the angioplasty immediately, and we have done this angioplasty, that is from ostium to the left main to the proximal part of the left main, keeping 1 to 2 millimeter hanging in the aorta, not much more. This is very important. And left anterior in aleocranial view is the essential for showing the left main ostium. That is not shown here, but it has been done. And port, after implanting the left main stent, and port is done, and you see here the area is significantly increased. And this is the final view of the left main ostial angioplasty. And case scenario 2, I am not giving the history. You see that is the lesion in the distal left main involving the ostium of the left anterdescending artery, as well as ramus intermedius or high OM, and we have done angioplasty to the ramus intermedius, and after then we have done the crossover stenting or single stent strategy from left main to LAD and post dilated it, and this is the result after post dilatation, and this is the final result on the right panel. And if we see the third scenario, we have done it transradial approach with 6 in 7 sheath, meaning that outer dia is 6 and inner dia accommodates it 7 guide, and it is very easy, and we have done it on the anatomical snap box. And here in the previous picture, I have shown that in the left circumflex, which is wider than left anterior descending artery, and angle is almost 70-80 degree, and we have done it by DK crash. And you see, this is the one important thing you mind it, that left circumflex is approximately 4.5, and that is why we have given the stent to the left circumflex 4.5 millimeter dia, and crash has been done, first crash, and then here we see the first case, and after that removal the wire from the left circumflex, and second crash by the stent in the LM to LAD, and crossing into the left circumflex, preferably by proximal or mid cell, not distal cell. Only this one is different from other bifurcation stents. And this is second case, and after that report is done, and this is the result of the report. This is the result of the report, and case another case, that is the left main mid as well as ostial left main LAD disease, as well as ostial left circumflex and downstream disease in the left circumflex. So we have decided to do double stent strategy and pre-dilatation, both the LAD and LCX lesion, and then LM to LAD stent is deployment is in progress. And after deployment of the stent LM to LAD, we remove all the wire from the left circumflex, and port is done. And after port, we re-enter into the left circumflex, dilated the strut, and after dilating the strut on the right side, you'll see very nice picture of a stent, that is a left circumflex stent, just one coil inside the left main. And then final kissing balloon inflation, both the LM to LAD balloon and LM to LCX balloon, and this is the report and the result after this report. We have not covered the entire left main. And another case, you see, this one is initially it showed that only ostium of the left main was diseased, but in IVAS it was found that ostial LAD as well as ostial SAR is also diseased critically, and so we have done it wire into the both LAD and LCX, and stent deployment is in LM to LAD, and port was done, and after PCI, and this is the result, LM approximately 4.5. Next further dilatation done, post dilatation done, and this is the result after the post dilatation. And this is the last case. Here we see that ostium of the left circumflex as well as ostium of the LAD is diseased, and pull back IVAS from the left circumflex to the LM first done, and distal LM is approximately 5.94, ostial LCX 3.46, and ostial LAD is 3.5. And so we decided to do double stent strategy, and pre-dilatation of the LCX and LAD both, and LM to LCX was a stent deployment is in progress, and after that we recross into the LAD, and then we opened up the strut and placed the stent from LM to LAD, and once again re-enter into the left circumflex, and opening up of the stent struts, and post dilatation done, and final kissing balloon inflation, LAD and LCX done, and report is done, and this is the result. Left anterior descending approximately 5, and ostial LAD approximately 4.5, And this is the final result after the procedure. And my take-home message, nothing is complete alone. We still need an integrated approach with clinical manifestation, angiography, IVAS, or OCT in making our decision for unprotected left main stenosis. In left main disease, involving both branches, stent technique should depend on individual patients' anatomical characteristics, operators' skills, but a provisional strategy may be effective. And in most of the cases, approximately 70% of the cases, we do provisional stenting, and second double stent strategy, usually approximately 30% case is required. LMPCI should be done by an experienced and appropriately equipped PCI team, and IVAS guiding in LMPCI is needed for lesion severity assessment, stenting, and selection of appropriate device and stent sizing. Moreover, minimizes the mess. And thank you all. This is my cath lab team, and I am grateful to my cath lab team as well as doctors who work with me. Thank you. Thank you once again for hearing these topics at late night. Thank you.
But not late night. Night is still
Thank
young,
you very much,
sir.
Professor Jamaluddin, sir. Nicely depicted multiple case with left brain bifurcation, and he nicely addressed current left brain landscape, how to select the best option. So I must appreciate. Now we are waiting for the most exciting case, actually. That is very, very interesting case. So I am requesting Dr. Bharat Purohit to please, can you share your slide? And he is the cath lab director of the Care Hospital, Hyderabad. And you know, he is a very legend in South India, and he is awarded Legend of the Year Cardiology Award from 2017. So I am requesting Dr. Bharat Purohit, because his case is really excellent. I think you should enjoy and you can learn a lot from this talk. Thank you very much, Dr. Bharat Purohit. Can you hear me? Dr. Bharat Purohit, can you hear me?
I have seen you.
Can you unmute?
Unmute it, please.
Can you hear me now?
Yep. Loud and clear.
Thanks, Dr. Arun. Nice to see you here after so many days. I enjoyed that workshop we had in our hospital, the ADR workshop, and I remember how nicely you did that ADR when it was almost late in the night.
Yep. Good old days, my friend.
Yes. It's nice to see you back again. Heartening to hear that you have started your own hospital in Chennai. Great. So thanks, Professor Azam and BSCI for giving me this opportunity. And it's almost 11 o'clock or 11:15, I think, in Bangladesh, around 10:40 here. So it was really excellent session, and I didn't realize that the time has passed so fast. I joined at around, I think, 7 o'clock India time, and now it's almost 11. And such wonderful talks, starting from Dr. Ashok and Dr. Arun and Dr. Imad, Siban and Emmanuel, everybody, amazing cases. And I'm just showing an interesting case which I came across. Something similar Dr. Seth has also shown in his slide. He did it in a different way, but I will show you how I did it in a different way and why I choose that particular technique. And this was a 75-year-old gentleman, diabetic, hypertensive. He had significant angina and normal LV function, and he came with this history. We did an angiography which showed a triple vessel disease. You can see here the proximal RC has some lesion here, you can see, and then this is the LA caudal view. You can say there is a significant ostial LMCA lesion, and there is a tight distal LMCA lesion. And what is most interesting is that the distal LMCA ostial LAD lesion, there is an aneurysm, and this is a dominant circ. You can see it here, and some lesion in the OM here. And ostial circ also has got a tight lesion. The first option in this scenario is, you can see here all the views here. Now you can see the LAD also has a lesion here, and ostial circumflex has a lesion, the ostial LMCA, distal LMCA, and there is on top of that, there is a huge aneurysm which is at the distal LMCA and ostial LAD lesion. So we all know that aneurysms are very uncommon, so we do not know what is the best way of treating them, and we call them an aneurysm only when they are more than 1.5 times the diameter, and they are extremely rare, around 0.15 to 5% of, and whereas LMC aneurysm only they are 0.1%. Now I'll not go into the detail. So the question was, what should we do? The first option everybody thinks about is doing a surgery. He's a 70-year-old gentleman, you do a surgery, you just cover the proximal and the distal clipping done so that there is no flow into the aneurysm, and then you put the grafts. Now, but the problem here, which I thought was, yes, we can put a graft, but what if one of the grafts closes? If because we will invariably put a Lima to LAD and SVG to circumflex or an OM. Now, what if the patient develops a blockage in the SVG graft, and we very well know that the outcome of the grafts is unpredictable, around 5 to 10% they close within 1 year. And if that happens, this patient is going to have a significant angina and I won't have any access there. So should we go ahead with a covered stent? But if you put a covered stent from left main to LAD, you are going to knock off the circumflex. That is again going to be a major catastrophe for this patient. Or shall we go with a conventional way? Many a time people suggest that you just put a simple drug-eluting stent, and it is something like a flow diverter which we use in the cerebral circulation. You just put a stent like you have this mesh covered, the NGARD stent, and it will reduce the flow in the aneurysm, and you can collapse it. So all these options were discussed with the surgeon, and finally we decided to go with a little different approach. And with this age and other comorbidities, we decided that we'll keep the surgery pretty simple. That patient will go with a off-pump CABG with a Lima to LAD, SVG to OM, D1, and RCA was done at the first sitting. Now, after 3 months, the patient came back, and we planned this, that once the patient is stable, we will go ahead and take care of the aneurysm in this sitting. So after 3 months, we did an angiography, and you see this is what the aneurysm is still there. The LAD circumflex lesions are still there, and you can see the competitive flow here suggesting that the Lima is flowing well. And this is the huge aneurysm which is there, almost like a chicken wing. And if you look at the grafts, this is the diagonal graft, SVG2 diagonal graft, flowing very nicely. The RCA graft also is doing well. But what is most interesting is if you see this graft which was put to OM, this graft has started showing restenosis at the anastomotic site. And that is what I was fearing when I was initially planning for the procedure in this patient. What should we do in this scenario? And my worst fears were coming true in this patient. And to see in another angle, this, of course, this is in the distal part, but the proximal part also has started showing narrowing. And you can see that the distal part of the anastomosis has a significant lesion. I hope you can all appreciate this tight lesion here. So what we decided is we will address this aneurysm by the same technique which the neurointerventionists do for their aneurysm in the brain. So first we decided to put a stent, and we crossed the LAD. Conventional wire was not crossing, so we took a Fielder XT and dilated with a 2 and 2.5 millimeter balloon. And then subsequently I exchanged it with a Renato wire, and then at this point of time I put one small wire in the aneurysm also. And through this wire I pushed a microcatheter, the rebar 18 microcatheter was pushed into the aneurysm, so that I can take care of it later on. And then what we did was we implanted a stent from left main to LAD, and the microcatheter is still there. So we put a stent from left main to LAD here, and after seeing that yes, the stent has been deployed nicely, we pushed coil into the aneurysm. Now, because of the presence of a stent in the left main to LAD, there is no chance that this coil is going to come back into the main vessel. So this technique that we use is called a stent-assisted coiling, which the neurointerventionists do very quite often. And I checked the position of the microcatheter in multiple views, and you can see all the views. The flow in the LAD is absolutely perfect. And at that point of time, you can see a small coil. You can see this thread light black line. This is the coil which is coming. It's a 3 into 8 concerto coil and detachable coil actually. So it has been pushed into the aneurysm here, and the coil is quite flexible and a soft coil, nylon coil, and it takes the shape of the aneurysm very nicely. And just one coil was enough. And you can see after putting the coil, the flow is still maintained in the circumflex and the LAD. So this helps me that in future, if it is needed, then I can always access this circumflex and I can go ahead and put a stent here. Right now, the patient did not have angina, so there was no need for me to do anything. But if I do anything, then the competitive flow may further aggravate the stenosis which is happening in the graft. So we checked in all the angle and then we detached the coil, and you can see the flow in the LAD is nicely maintained. It's a good flow here without any compromise, and the aneurysm is nicely closed with the help of a coil there. And the circumflex stenosis is still there. The flow in the grafts are still maintained, and this is where we stop the procedure, and you can see the aneurysm is almost completely closed here. So when I looked into the literature whether something similar has been done in the past, and I could get only two articles I could put where the people have tried something like this. So, but when I started, honestly, I didn't know that something like this will work also. And I discussed with my neurointerventionist about this technique. They said, yes, it's a big vessel, and you can always go ahead because we have been doing this quite regularly. My first worry was when it starts thrombosis, what will happen to the main vessel? They said if the thrombosis never extends into the main vessel because these are high flow situation, nothing will happen. Only thing which will happen is the aneurysm is going to get closed, but the flow will in the main vessel will always be maintained. So no need to worry about all those things, and that gave me a confidence. And this is how we completed our procedure. You can see, and this is almost now I think 7 months over for this procedure. The patient is still doing well. He never didn't have any angina, and he is on dual antiplatelet therapy. So thank you very much for waiting so patiently till 11 o'clock and hearing me speak on something like this.
Thank you, Bharat, for your actually excellent case. And it is a really a common difficult, not common, very uncommon difficult scenario. I think you nicely demonstrated, and we have some panels, and after panel I will go back to our chairpersons. Any panel, Professor Shahabuddin sir, I am seeing you. Can you make any comment for this case?
Yes. Thank you, Professor Azum, and thank you, Professor Mir Jamaluddin and Professor Ikram Rahman for inviting me in this panel. This is an excellent, wonderful presentation. I have listened all the discussion, all the lectures that were brilliantly and vividly and excellently presented here. This is a new dimension for learning curve through this COVID situation in such a way. I thanks the organizer for arranging such a program and giving the thanks to the speaker. All of these speakers, they have demonstrated very vividly and very excellently. And all are the masters of the masters. Thank you all. Thank you, Professor Mir Jamaluddin, once again for your invitations.
Can you put a question, please, to Bharat?
No.
Yes.
Dr. Bharat Purohit, actually, I did a case but without coiling, only stent, because the guideline recommend nothing in this regard, especially for aneurysm. And everybody actually discouraged to do this type of procedure. But I did 2 to 3 cases, but not coiling, stenting, but the aneurysm was there. And antiplatelet drug, I have managed the letter of the patient with the antiplatelet. So which type of antiplatelet actually you use for the rest of the life?
This gentleman, if you remember, we have done only 7 months back. So the patient is still on aspirin and ticagrelor right now.
Any warfarin or novel anticoagulant?
No, we didn't give it because when I checked with my neuro colleagues, they said they also don't give any anticoagulant when they do stent-assisted coiling. And so that's why we also did not use anything.
But my experience, this is not no guideline, but I do not do any coil. But that patient, when without only aspirin and clopidogrel, the patient was complained of angina after some, but angiogram after the check angio was normal. But when we add actually warfarin after some day, he actually patient actually there was no complaint. So actually, I don't know about interpreted guideline what said actually.
Yeah, if you see the complication which happens in aneurysm, the one of the important complication is small embolization which happens distally.
Yes.
Some thrombus will fall and keep going distally.
Yeah.
So if we are not tackling the aneurysm with the help of a stent graft, if you still do with a conventional stent, then the flow in the aneurysm is still going and there is a slow flow. Small clots will be forming, which will come through the stent strut and it will go distally, giving rise to angina. So in this situation, we have to give them anticoagulant to tackle this. So if you are just medically managing also an aneurysm, it is always better that you give them single antiplatelet and an anticoagulant rather than only double antiplatelet. That is what I have been doing all the time.
Another question actually, once upon a time, the interventional operator actually used the distal embolic device in case of where there is a fear of embolization of distal in this type because the aneurysm was thrombus burden. So nowadays, actually, the distal protective device was very less used. So in India, actually, in case of carotid neurointervention, sometimes used, but any cardiologist, in case of saphenous vein grafting or stenting, in case of at that time, any distal embolic device was used or not?
See, if we are doing a SBG graft, definitely we go ahead with a distal embolization protection device. If it's a very degenerated 10-year, 12-year-old degenerated graft, definitely we prefer to use a embolic protection device. But in other cases, we have stopped using in coronaries the distal embolization protection devices. In carotid, yes, definitely it's a class 1 indication. You have to use a distal embolization protection device when you are doing a carotid intervention, unless it's a radiation-induced or it's a Takayasu, where the atherosclerosis is less. You may not use it in those two situations. Otherwise, if it's atherosclerosis, it is always better to use a distal embolization in carotid.
Dr. Bharat, in carotid stenting, some people are doing carotid stenting without distal protection device, and they says that the result is almost similar. 1 to 2% embolic manifestation occurs if they do not use distal protection device.
There is a difference. There is a difference between the approach of intervention radiologist and cardiologist.
Exactly.
To ask the cardiologist, invariably all the cardiologists will go ahead and use a distal embolization. And if you look at the guidelines definitely say that you have to use a distal embolization. But intervention radiologist, I have seen little hesitancy in the part of intervention radiologists to use distal embolization protection. But if you ask me personally, going by the physiology, going by the plaques which have been by the atherosclerotic debris which have been captured in the protection devices, I will always prefer to use a embolic protection device. Most of the trials which have been done, they have always shown the protection device showing a better result than not using it.
Thank you, Bharat. Actually, every case is unique.
Ajum.
Yes.
Open your camera, sir. Video.
Hello. If he is not connected, so can I request Dr. Ashok Datta? Are you here? Can you make any comment?
Yes. Regarding this case, that is a very interesting case, and I really learned from it. And in future, I will try to do it. Actually, what Mustafa was telling, if you don't keep the coil outside the stent, there is more possibility of formation of thrombus throughout the life and distal embolization. But once you put the coil outside the stent, that part will gradually be endothelialized. So I think in that case, this is the advantage that only dual antiplatelet, even after 1 year, single antiplatelet will be enough. But if you put the gap outside the stent, there will be always a space for thrombus formation. So chance of embolization, thromboembolization is more likely. So in that case, either warfarin or novel anticoagulant you can give. Thank you.
Thank you, Ashok Datta. Thank you, Ashok Datta. Now, Professor Amol Kumar Chaudhary tried to, I think, raise any question or issue. Professor Amol Kumar Chaudhary?
Question.
I like to thank BSCI for this great session, arranging such a great.
Dr. Bharat, this is the middle of the night.
Yes.
Thank you very much for your excellent, exceptional case presentation. Just I want to know, before surgery, the aneurysm is the single isolated one, but after that, it is still isolated one. What may be the underlying cause of this aneurysm?
It's an atherosclerotic aneurysm. If you look at 50% of aneurysms are atherosclerotic. There was a small bit of aneurysm, if I can see. I can say it is aneurysm, it's just little ectasia, which is seen also in the circumflex. So I think it is the atherosclerosis which is giving rise to this aneurysm. One tip I will suggest if somebody is thinking about doing this kind of procedure is you must put your microcatheter first inside the aneurysm. Then you put the stent. Otherwise, it will be difficult to go through the stent into the aneurysm. So always your microcatheter should be jailed between the wall and the stent. And later on, after putting the coil, you remove the microcatheter and you can optimize it again.
That jailed microcatheter that does not produce any resistance to No, that will be easy.
Nothing will happen. It's a pretty slippery and hydrophilic microcatheter. It's Rebar 18 which I took. So you can safely keep it. If you are not keeping it and thinking that I will just cross it just like a bifurcation stenting, I will cross the stud, very, very difficult.
Thank you, Bharat. Actually, you give us a great opportunity to learn a lot from a very, very difficult case. Now, we are very close to our session, very close to session. Just before going to closing our session, I just make a quick comment from Dr. Arun Kallansundaram. Arun, are you here?
Yep. Guys,
yes, you just make it.
So, Professor Azam and BSCI, I mean, I think it's a fantastic show. I mean, I have to kind of echo what Dr. Bharat said about, I logged in pretty early and time flew. It was fantastic, great talks, great moderation, really enjoyed it. I think most of the points have been discussed, and I think you really covered the gamut. I think the core committee that put this together, kudos to you guys. Glad I was part of it. Thank you so much.
Thank you, Arun. Thank you, Arun. Stay safe. And now we are trying to closing our sessions. Before closing session, I request our Secretary General, Professor Mir Jamaluddin sir, give a small brief overview. And after that, our Professor President, I requesting our President get ready for his conclusion remarks. And he will announce an exciting announcement. I think, hope you enjoy and stay well. Professor Mir Jamaluddin sir, can you, sir, start?
Thank you, Professor Azam. We are grateful to all the participants to attend our virtual summit, and practically our regular summit was on April, but due to COVID era, we have to decline from April and coming up to this October by pushing. Even then, we are at the moment we are without practically. It is done by virtual. But we had an idea that we should do it like a conference. And somebody, even you also told to do it 2 days, but we have decided to take in 1 day. But now it is, I feel, with the participation of our young cardiologist, it shows that 2 days was better. 1 day is horrible. That's from 8 a.m. to night 12 p.m. Anyway, we are grateful to our faculty members, our committee members who have given tremendous effort to make it success, and we are also grateful to our foreign speakers, those who have given the response to our invitation. They have given time and they have given us knowledge, and so we are also grateful to them. And we are also grateful to the pharmaceuticals pharmaceuticals as well as the device companies who gave us support for doing this program. And I declare that now our president will give the of our CD presentation, and he will put the session. Thank you all. Thank you for kind participation.
Thank you very much, Secretary General, regarding concluding remark. I also thank all participants, all faculties, and all panelists for this our seminar. All faculties, especially our foreign faculties and national faculties, they delivered their lecture in the respective session. Very, very informative session for us as well as our young fellows. I think it should be beneficial for the young one. Now I have two parts. One is the concluding session. Another is very, very exciting for award-winning ceremony. Now I feel very much pleasure to declare it. Actually, every competitor of this session, award-winning session, they do well. Our chair, Professor Fuzilatun Nessa, Professor Hafiz, and Professor Surabud Jaman, and our distinguished panelists and moderator, we take the views, but they are all in confused. Which one will be the first? Which one will be the second? We are also very much confused from the BSCI authority. Anyway, we want to conclude, and now I am feel pleasure to declare the result of this award-winning CD. Among 9 competitors, I declare with honor to Dr. Farhana Ahmed. He is the first one for presenting his case zero contrast, and Dr. Momen is the second one. It's very interesting case and in the mechanical complications. And the rest of the competitor, we are facing very much difficulty which will be the third one. So we decided, along with the opinion of our chairperson, panelists, and others, and our BSCI authority, all the rest of the competitors is the third one. So we will give award to everyone, and this is the result of this award-winning ceremony. Now, in conclusion, and last of all, I want to say, we are planning to do this seminar from the April of this year, but due to this scenario of the COVID era and facing some difficulties, we have to sit up to October. I think this is a very enjoyable and memorable seminar, and we are planning to do our next seminar in 2021 in the March 11 and 12. All will be invited, and according to my Secretary General, we will try to make this seminar maybe in the 2 days to get it a long time. It is a day-long program. Now it become the day-night program. So I thanks again all, especially my members of the executive committee and BSCI member and foreign faculties and chairperson, panelists and moderators, and the award-winning all participants, and also Beximco pharmaceutical, other pharmaceutical device company to help us to make this program a grand success. Wish you all good luck, be safe, and be blessed. Thank you very much.
Thank you, our Professor A.K. Fazlur sir, for his concluding remarks and to declare the end of the session. And I must acknowledge our foreign faculties, our friends and colleagues. Without your support, we couldn't able to make our program successful one. So hope to see you our next program. Please stay safe